Mr. Scott.
Good morning, my lady. May we please call Catherine Todd, who can be sworn.
Mr. Todd, if you could repeat after me, please. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth and nothing but the truth.
the whole truth and nothing but the truth.
Thank you.
Ms. Todd, thank you so much for joining us this morning. I know how difficult this must be for you. Probably something that you don't want to relive, but it is so important that we do hear from you, so I'm really grateful to you.
Thanks.
Miss Todd, I'd like to ask you some questions about the experiences of you and your partner TJ around the very sad death of your son Ziggy on the 21st of July 2021, a few hours after he was born. It's right that Ziggy was your first child.
Yeah, he was.
And are you happy if I refer to him as Ziggy throughout?
Yeah, that's fine.
On the 12th of July 2021, you were approaching 28 weeks pregnant. Is that right?
Yeah, that's great.
You'd been due to attend a routine scan, but you tested positive for COVID. So you called the hospital's maternity unit. What did they do as a result of that call?
When I first phoned and reported to maternity that I was COVID positive, they had cancelled a scan that was upcoming.
Did they give you any guidance or advice about what to do or things to look out for as a pregnant lady with COVID?
No, not at that time.
You started to feel very unwell, but you also became aware that Ziggy wasn't moving the way that he had been. What did you do as a result of that?
I'd phoned maternity, both the EOU and the advice line, multiple times. Their advice really at the time was just to take paracetamol and lie on my side for 2 hours and drink a fizzy drink.
That seems fairly normal advice you get for a pregnant lady who's suffering from reduced fetal movements. Were you being told anything above and beyond that because
No.
you had COVID? And for how many days did you call?
I think I first phoned maybe on the 12th or the 13th, sorry, maybe, to say that I had COVID, and then up until Siggy was born, so up until the 20th, I had an ambulance out as well to our house in between the phone calls.
Mr. Scott, can you pause that? I'm not sure if anybody else is having some problems following the audio. And is it just me? Looks like it's just me. Nobody else is nodding, so I'll look at the transcript.
Well, you're quite important, my lady, so if there's anything that we can do to make that
I've got
better.
the transcript, and I think as long as the stenographer can hear properly, that's fine. I'm so sorry to have interrupted, Mr. Todd.
What advice were you being given in those first few days, so the 12th, the 13th, the 14th, when you were calling the maternity unit?
Every time it was really the same, just lie on my side and to phone back if I had any other concerns.
Did you ask for Ziggy to be checked?
Yeah. Mm-hmm.
And what did they say?
They told me that they wouldn't bring me in at the time because they wanted to reduce the risk of spread of COVID.
And how did that make you feel?
Not reassured at all.
Do you think that you should have been examined sooner than you were?
Yeah, definitely.
Do you think that you would have been seen earlier if you didn't have COVID?
Yeah. Mm-hmm.
And it came to the point that you took yourself to hospital on the 16th of July. Is that right?
I had phoned them a few times on the 16th. Again, they gave me the same advice, just to lie on the side, drink a fizzy drink, take paracetamol. But a few hours later, nothing had changed. So I phoned back again and said that I was coming up for the hospital to check Ziggy.
What made you take the decision to go up?
I just felt at that time it had gone on too long, and I was just getting the same advice and nothing was changing every time I was phoning.
And when you went up, it's right that you were 27 weeks and 6 days pregnant that day, is that right? Yeah. And when you went up, you have a partner, TJ, that's right?
Yeah.
Did TJ go with you?
He wasn't allowed into the hospital. He had to park outside, and they brought me through an ambulance bay just to be seen.
Were you told when, at any point, TJ may be allowed in while you were in there?
I was told that he wasn't allowed in at all.
And when you were in, you didn't receive a full, I'm going to call it a CTG scan, but you received a Doppler scan, so just a normal scan to listen to the baby's heartbeat, is that right?
Yeah, just a Doppler.
Was the midwife who carried out that scan wearing PPE?
I think she was. It was the sister that had seen me. Although after she'd done the Doppler, she had told me to go back and wait in the car, that she needed to do a handover. She'd been there from 7:30 that morning, and that I was fine and Siggy was fine. And while I was waiting in the car for my notes to be brought out, she actually came out in her own clothes.
How long were you waiting in your car for?
Maybe about 5 minutes after the Doppler was done.
How did you feel being asked to leave the maternity unit and go and wait in your car before you got your notes?
Like I was just rushed in and out the door. No one really wanted to see me.
You provided a review of the circumstances of Ziggy's death. One of the points that's considered in that review is about the decision not to give you a CTG scan.
Yeah.
And please do correct me if I'm wrong, but is it right that the guidance that was in place at the time for the hospital was that assessment of fetal heart rate by CTG was from 28 weeks onwards?
Yeah, that's correct.
And because you were 27 weeks and 6 days, a CTG was not performed?
Yeah.
Were you asked to come back the next day when you would have been at 28 weeks?
No. I was just sent home and told that I was fine, and that Ziggy was fine.
Were you told what to do if you still had concerns about Ziggy's movements or lack of them?
No.
So, sorry to interrupt again. Mr. Todd, what was it about Ziggy that made you feel that you'd had to go to hospital? What was it about the baby that made you think there's something might be wrong?
Reduced. And then I had also noticed my bump getting quite a lot smaller.
So I don't think the sonographer heard. What reduced? Was that the movement of the baby? Was it Ziggy's movement? So Ziggy's movement reduced and you thought your bump was smaller, so you thought he was smaller?
Yeah.
And when you went in on the 16th of July, for how many days had you been concerned about reduced movements from Ziggy?
Maybe from the 14th onwards.
Just if I can come back to the review about that in relation to the scan. It's also noted that the impact of maternal Covid-19 was not fully understood and led to this not being recognised as an independent risk factor when assessing reduced fetal movement. This resulted in you not having a CTG recording when you attended on the 16th of July 2021. And it continued, at the time of the review, limited information was available about the effects of Covid-19 during pregnancy, particularly the strain of virus which was prevalent in Northern Ireland during the summer months of 2021. They were not obvious within the obstetric teams in Northern Ireland until late August, early September 2021. How did you feel about that finding when you read it?
Very let down. Don't know why it took even past a year into the pandemic for them to have anything really in place for maternity.
In July 2021, had you heard there being concerns about risks associated with COVID during pregnancy?
Not really, no.
What's your thoughts about not being offered a CTG scan? How's that had a lasting impact upon you?
I think that if they had have done the CTG, they possibly would have picked things up and things could have been completely different.
Do you feel that you were able to ask or insist or press for a CTG scan?
No. As I say, I felt like I was rushed in and out. No one really wanted me in the hospital for a start, obviously because I was COVID positive. So I think at the time they were just trying to get me out as quick as they could.
Do you think the situation might have been different if you'd been allowed to have TJ or anyone else in with you?
Yeah.
So moving ahead, about 3 days later, you were having difficulty breathing and you were having heart palpitations. How concerned at that point were you for both yourself and for Ziggy?
Extremely concerned. I actually ended up phoning my GP the following day from having the ambulance out, because when the ambulance did come out, they just checked me, but not Ziggy. And I was at the time I was kind of up and down. 1 minute it was okay, and then breathing wise, and then the next minute breathing wasn't great. I think maybe it had taken the ambulance about 5 hours or so to come out. But the following day my breathing had got worse, and I just felt like the hospital and when the ambulance came out, they hadn't really done much. So the following day is whenever I'd phoned my GP.
Can I just
Yeah.
sorry? Can I just take those in steps? So, what were you concerned about with Ziggy that led to? I think it was TJ who called the ambulance, wasn't it?
Yeah. Mm-hmm.
So, what were your concerns about Ziggy that led to the ambulance being called?
Well, I'd obviously noticed his movements reducing, and then the sicker I was feeling, it was concerning me more that the two of us were really unwell at that point.
And I think you said it was 5 hours.
Yeah, I think it was around there.
And that was for the ambulance to arrive from the time it was called.
Mm-hmm.
And it arrived about 1 or 2 a.m., is that right?
Yeah, that's right.
And you said earlier on that when the ambulance arrived, they didn't check the baby. Do you remember anything about why the paramedics didn't check on Ziggy?
No, they didn't tell me why. They just basically done my oxygen levels and blood pressure, and that was it.
Did you tell them about your concerns about Ziggy's lack of movements?
Yeah, I was more so phoning for him than me at that point.
Were you given any advice or guidance about what you should do?
No, just the same thing again, take paracetamol and lie down.
So you were told to lie down. That was from the paramedics, you were told to lie down when they just checked you?
Yeah. Mm-hmm.
This was on the 16th of July, so you'd already been in this for a few days at this point, 4 or 5 days. What was your state of mind at that time when the paramedics left?
I think being checked by both the sister in EOU and the ambulance, I was kind of thinking at the time maybe everything was okay, as that's what they were telling me. And just to kind of to trust them when, and I know that I shouldn't have, I should have kind of pushed it further.
Did you feel looked after?
No.
So you said earlier on that you called the GP about midday, so that was about 11 hours or so after the ambulance had arrived. Could you tell us, please, what the GP said to you?
She said to go straight to A&E, and that she was going to fax over that I was coming so that they definitely had to see me.
Did she think that you might not be seen if she hadn't informed them that you were coming?
I think so. I think she also had faxed it over so I kind of wouldn't have been waiting as long. But I don't really think it made a difference because obviously I was in A&E then waiting for maybe about 10 hours.
So you said you went to A&E and you just said you were waiting in A&E for 10 hours?
Yeah.
Was that 10 hours until you were seen or 10 hours until you left or?
10 hours in A&E in total until I was moved over to maternity. I think about 5 hours in, obstetrics came down and scanned me. I seen Siggy and stuff moving then at the time.
Well, sorry, Mr. Todd, I don't want to jump ahead too quickly. I will definitely get there with you. I just want to talk about your waiting experience in A&E. You say that you were placed in what seemed to be a waiting area for people with COVID, but it also seemed to be used for people with suspected COVID. What made you think that?
There was a man who was shouting everywhere about how he wasn't COVID positive. I think he was maybe up for like an asthmatic problem, and they had just grouped his symptoms together basically and put him in the COVID area of A&E.
So it was July 2021. Was there any kind of funneling system or areas for people to wait depending on any kind of COVID status?
At the A&E that I was in, they had so the normal waiting room of A&E was people that they didn't suspect to have COVID. Then they had a door that was like locked and security, and beyond that door was just everyone with either COVID positive or they had COVID symptoms.
And was that where you were because you had the positive test?
Yeah.
Okay. So you just said that in A&E that they scanned Ziggy and that you could see him moving. Were you given the results of that scan?
No.
What were you told?
That he was fine. But their concern at the time was a deranged liver function test that was done on me, but they had no concerns really for Siggy.
You talk about how that you thought that the staff were all called into a meeting.
Yeah.
Did you feel that everything was fine with Ziggy at that point?
I did, yeah. Mm-hmm.
So, were you taken from A&E round to the maternity ward?
Yeah, a midwife actually came down with a wheelchair to take me round to maternity from A&E, but that was another 5 hours after he was scanned.
Was TJ with you at any point in this?
No, he wasn't allowed in.
Where was he? Was he in the car park or somewhere else? Or
At home, we only live maybe like 5 minutes from the hospital, so he stayed at home.
when you were scanned around in the maternity ward, how many people were at that scan?
Maybe about 4 or 5.
And what were you told were the results of that scan?
That Siggy had very little amniotic fluid around him, and they were going to take me for an emergency section.
Did you have a chance to talk to TJ at that time?
So I just texted him really quickly, and then they have prepped me for the section.
Just before you go on, Ms. Todd, just before the prep, because you talk about the alarms going off.
Yeah.
How long were you left after the alarms went off?
An hour.
Were you told what was happening?
No, no one came in at all.
How did you feel about being left in that situation?
Really unsafe.
Why do you think that there was a delay in carrying out that emergency C-section?
We had a meeting maybe December time with a few of the staff, and they had told me the delay was because there was another baby that had, I think, an 80% survival rate, whereas at the time Siggy only had 10, so they chose basically to go in with the other baby.
Do you think that there was enough staff there to be able to treat you and to give Ziggy an early C-section?
No, not at all.
Did anybody contact TJ to tell him what was happening at this time?
No, he actually contacted the hospital a few times himself. The first time, I think he was told if I needed him that I would phone him, to which he replied, if she's in having a section, she'll not have her phone. And then he phoned another 2 times, I think, and they told him to stop ringing, and that it wasn't his information to know.
Did anybody else try and contact?
Yeah, my mum and my eldest sister, and they were told the same thing.
So did anybody know when you actually went in to have the C-section?
No.
When was TJ allowed in?
I had the section and then brought back up to a room, so it wasn't until later that night, a few hours maybe after Siggy was born.
Obviously, how did TJ feel in that time between when he found out that you were having a C-section and when he was actually allowed to see you?
I think he was very anxious. He was at home with no information of what was going on. He was completely left in the dark.
What happened to Ziggy after you'd had the C-section?
I know when he was first born, he had a very low AFGAR score. So they had him basically in the corner with the team for the NICU. They had done CPR and then taken him up to neonatal intensive care.
Did you have a chance to see him?
No.
So when he was in the neonatal unit, did you have an opportunity, or put that a different way, did the nursing staff try and help you and TJ see Ziggy over that night?
They tried to bring us round a few times during the night, but they didn't explain that they were bringing us round. They were just kind of putting me in full PPE and into a wheelchair, and then the next minute I was back. They were getting me back out of the wheelchair, and the PPE was off again.
What room, were you in a room or were you in a ward at that time?
I was in a private, like a side room. I think it's actually the bereavement room. It's in the hospital.
So you didn't have to be in PPE in there?
No.
Was TJ allowed to be in with you there?
Yeah. Mm-hmm.
Was he allowed to be in there with you all night, or did he have to leave?
He, as soon as he came into the hospital, he stayed with me then in the room. We actually had a midwife who came in and sat on, this was after Siggy had passed, sat on the floor and told him that he wasn't allowed to leave. He basically said he hadn't left, and she said, that's fine, you shouldn't even be here, or we've already bent over backwards for you, you shouldn't even be here.
How did it help you to have TJ with you that night before Ziggy passed away?
I think it was more so the support, because I hadn't been given that option the whole time of, Siggy's movements reducing, he wasn't allowed into any scans, and then again in A&E. So I think it was more so the support, and he obviously was in the same boat that I was at the time. No one was telling us anything, so it was just the two of us kind of talking with each other.
Did you know how unwell Ziggy was that night?
At the start, they'd said that he was really unwell. But then later on, one of the midwives had made a comment that his obs had been picking up. That was just before we were brought round to meet him. So we actually thought that he was getting better, a good bit better, before we'd been brought round to see him the next day.
Do you think the fact that you were COVID positive had anything to do with the amount of information that you were being given about Ziggy's condition overnight?
Yeah, I think they were trying not to come in and out of the room as much as probably what they would have if I wasn't COVID positive.
Were you or TJ receiving any food and drink, for example?
Yeah. Mm-hmm.
You went round and saw Ziggy, was it about 8:30, 9 o'clock the following morning?
Yeah.
What did you think Ziggy's condition was before you saw him?
As I say, the midwife had stated that his obs were starting to pick up, so we thought we were being brought round to meet him as he was getting better. We weren't told at the time that he was on palliative care or anything.
What did you find how was Ziggy when you went in?
He was basically in an incubator, in a private NICU room that actually overlooked the main neonatal. There was a window so people could see in, and we could see in there. But he had all the medical equipment on, basically, and when we came in, they had taken him off everything. Again, we thought that he was getting a lot better at that point, that they were able to remove everything.
When did you find out that wasn't the case?
But they took everything off and then handed Ziggy over to me, and then they just left the room, and then he passed away, and they didn't come back for maybe about another 2 hours.
Was that the first time that you'd been with Ziggy since he was born?
Yeah.
And was that the only time that TJ got to see Ziggy?
Yeah.
And were you having to wear full PPE when you were with him?
Yeah, I had the full PPE. We had hairnets, masks, a visor, a full apron, gloves, and I think shoe coverings.
What did you think about being asked to wear PPE to visit Ziggy?
I thought it was unnecessary, especially at the time. They knew how unwell he was. We didn't. So now looking at it, I'm a bit confused as to why we were in full PPE. Because if they knew that he was being taken off life support, I don't understand who the PPE was protecting. Also, he was in a private infection room. So again, I don't think it was necessary to have full PPE.
Did wearing PPE, does that have a lasting impact upon your memories of your time with Ziggy?
Yeah, all of our photos that we have with him are in full PPE.
How long were you with Ziggy for?
We were, after he had passed, as I say, they left us in that room for about 2 hours before they came back, and then they brought us back to the bereavement room. And I think, I'm not sure, but I think they possibly had like washed him and stuff. We weren't given the option again to do that, and then they brought him round to the bereavement room.
In those 2 hours, did anyone come in and see you?
No.
You said earlier on that in the room that Ziggy was in, you could be seen from the outside.
Yep.
Was there a curtain or a screen or anything that was put up?
Nothing. I think only after the SAI was done, because it was something that I highlighted, as there was another baby that was on the opposite side of the window, and the baby's dad, but I assume it was the baby's dad, was able to watch everything.
You stayed in hospital for some days afterwards. How much time was TJ able to spend with you?
He stayed with me the whole time then in that room.
How beneficial was that for both of you, that you were able to spend time together?
Really important. I think also it was really the only time that we got with Ziggy. So it was very important.
And you mentioned earlier on about the midwife coming over and saying, you can't be leaving this room, we've bent over backwards for you. Is that 2 days after Ziggy had passed away?
Yeah. He was actually on my chest at the time.
What was your overall view of the compassion that you and TJ and Ziggy received from the staff at that time?
I don't think there was any at all. I don't think anyone cared. I think they were too busy. They were rushing in and out of the room and just didn't really care.
Do you think they knew what to do, how to cope with COVID and pregnant people at that time?
No, not at all.
Do you think there was enough staff to be able to look after everyone in the maternity unit at that time?
No.
Were you offered any help with bereavement or grief while you were in hospital?
I later learned that leaving the hospital, we were supposed to have a bereavement midwife as we were leaving, which we didn't hear from until I think it was 2 weeks later. And she actually contacted TJ to tell him funeral arrangements that we had made.
You were told that Ziggy was to be sent for a post-mortem.
Yeah.
And do you know that, well, his body was going to have to be collected to be taken to a hospital in Liverpool for a post-mortem, is that right?
Yeah, that's right.
And do you know the reason for that?
No.
Had anyone ever told you whether there was anyone actually in Northern Ireland capable of carrying out a post-mortem on a child at that time?
No. That was really our only option, was that he went to Alderhay. And they, in the bereavement room, they brought round like a DVD to watch of stages basically and what would happen, from time frames to like who would be with him, and but obviously that didn't happen either.
How important was it to you to know where Ziggy was at all times in that trip to and from Liverpool?
Extremely important.
And were you kept informed about where he was?
No, not at all. We were told that he would be picked up from the Ulster on the Monday and back on the Wednesday. When in turn it came to the Monday, I had heard nothing at all, so I contacted the hospital myself, and they basically said they didn't know where he was. He wasn't there. They suggested that I contact the Royal Mortuary. So when I done that, they weren't sure where he was either, and they told me to maybe phone over to Liverpool. So I'd phoned Liverpool maybe that night, and again I got a guy on the phone who wasn't too sure. He said he didn't think there was any babies that had come over from Belfast, until the next morning. A lady from the Snowflakes team had contacted me to let me know that he wasn't there. And she'd stayed in contact with me, but then she phoned me again on the Wednesday morning. Following Tuesday night, she had told me that there was 2 babies coming from Belfast, but they didn't know their names until they got there. So she phoned me maybe at about 6 o'clock Wednesday morning to let me know that he had arrived in Liverpool. So he had basically been in the Ulster the entire time.
So, is it right that it was about 2 days where you didn't know where Ziggy was?
Yeah.
What did you think of the level of contact that you'd had from the hospital in Northern Ireland?
I thought it was appalling.
Were you able to have an open coffin for Ziggy?
In the end, but very nearly no. The Ulster had put on maternal COVID on his death certificate, and as a result, the funeral director's policy was that they wouldn't then be able to manage his body. And it was only from the lady actually that was working in the Snowflakes team over in Liverpool. She had phoned me just to see if we had a cuddle cot. And at the time I didn't even know what that was.
Could you just explain quickly what a cuddle cot is?
It's like a small Moses basket type shape device that keeps the baby cold, so you can spend more time with them.
How important was it to you at that time to spend time with Ziggy?
Extremely important.
How long?
Sorry, just because we'd even been told that it was going to be a closed coffin, you know, it was really important to us that we got to make memories that we could.
How long did it take for you to be given a cuddle cot?
When he came home, he was due to be home with the funeral directors, and because the lady from Snowflakes team had phoned, everything kind of had to be delayed, so we could arrange with the hospital to collect a cuddle cot. And I think, if I remember correctly, I think TJ actually had to go up and collect it himself.
And you're talking about an open coffin. Is it right that it was only when the funeral home were told that Ziggy had a negative PCR test that you were able to have an open coffin?
Yeah. So the lady from Snowflakes team was the one who organised it all. She phoned round the Ulster from Liverpool to ask if he had a PCR. Now, we were never asked or given consent for him to have a PCR done, but basically that's the only reason why. Is she then obtained it from the Ulster, and then she contacted the funeral directors as well to let them know that Ziggy's PCR was done by the hospital and it was negative.
This was a Snowflakes team. This is in Liverpool. It's not a Northern Ireland service, is that right?
Yeah. Mm-hmm.
How did you feel about the level of communication that you'd received about the cuddle cot, about the PCR that would allow you to have an open coffin?
Well, there wasn't any communication. You know, everything was done either by us or from another service that's not in Northern Ireland.
And is it right that after Ziggy's death and after the funeral arrangements, you tried to get access to the records that were held about you and about Ziggy? How easy was it to get access to those records?
Extremely difficult. We phoned and phoned, and a lady actually told TJ she wasn't so sure why I wanted them, even to begin with. And he said he had replied to her saying it doesn't matter why she wants them, but if it helps her sleep, then what's the issue that she's given them? And basically, then we were given half. We weren't given the full medical notes. We were only given half of them, and I think it was a few days even for them to photocopy that out. We've never actually received the green file. It's just been a photocopy.
Do you think it was a battle to get those notes?
Yeah.
Just want to ask about your overall impressions, Ms. Todd. When you look back on all of your experiences in that period in July 2021, do you think that there were enough staff to treat you at that time?
No.
Do you think that the staff knew how to treat a pregnant woman with COVID back in 2021?
No.
Did you feel safe as a pregnant lady in Northern Ireland?
Not at all. No.
It's right that you're pregnant now, is it?
Yeah.
Do you feel safe as a pregnant lady in Northern Ireland now?
No.
Did you feel listened to by medical staff in 2021?
No.
You've since given birth, as you say. Is it right that some of those who've been involved in your time with Ziggy arrived at your bedside at the time when your child was born?
Yeah.
How did that impact upon your experience with her?
I don't think it was necessary at all. I also was admitted the majority of my pregnancy with my second, and had people that were dealing with the SAI with Siggy at the time come round to see me while I was admitted with my second, which again I don't think there was any need for.
How has your experiences made you feel towards the healthcare system in Northern Ireland?
I don't have much hope,
And just finally, how are you now?
Not great. It's obviously something that's completely impacted the rest of our lives. And I think we have just been left to deal with it ourselves. We're kind of away from the hospital now, and that's all that that matters to them. We're out the door, and we're the ones left with this for the rest of our lives, basically.
Thank you, Ms. Todd. My lady, I have no further questions.
Thank you very much indeed, Ms. Todd. I do hope we haven't added to your trauma and your grief. No one can ever replace Ziggy, and I know that you and his father will never forget him, and you'll always miss him. I just hope that the new baby and your daughter can help you come to terms with the grief that I'm afraid is going to be with you forever. But thank you so much, and best of luck with the new baby.
Thank you.
Right, I think we'll take a break now, Ms. Todd. There may be some people who wish to speak with you, so Ms. Campbell and others may just come and repeat the thanks, I suspect, that I've already given. And we'll take a short break and then we'll come back to the next witness. Thank you again.
All right.
Okay.
My lady, before we call the next witness, can I deal with one matter? You've just heard now from 4 witnesses who are giving evidence on behalf of the bereaved groups from across the UK. And in addition to publishing their statements, the inquiry also obtained statements from 4 other individuals, Seema Bala, Sam Smith-Higgins, Margaret Waterton and Fidelma Mallon. And can I invite you please to publish both the 4 people that we've heard from and indeed those 4 additional statements onto the inquiry website?
Certainly, and I should say I was rereading the statements of the 4 bereaved that you're about to publish earlier today, and they're all as moving as the evidence we've heard over the last few hours. And also I should say that you mentioned, I think in your opening, about documents being published. The default setting will be publication unless there's a reason not to.
Thank you very much. We're very grateful. Can I now invite, please, Professor Clive Beggs to be sworn?
I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth and nothing but the truth.
the whole truth and nothing but the truth.
Thank you.
Thank you. Sit down. Professor, your full name, please.
My name is Clive Baron Beggs.
And you have provided, I think, a 132-page report to Module 3 dealing with the physical science underpinning COVID transmission and its implication for infection, prevention and control in healthcare settings.
Yes, that's the case.
It has the formal INQ ending 474276, and we will be going through a number of pages and paragraphs in it. I hope you have a copy in front of you.
I have, yes.
All right. Before we delve into the science, can I start with you, please, and a little bit about your background? It's set out at pages 4 and 5 of your report, but does it come to this, that you are a bioengineer and a physiologist and an emeritus professor of applied physiology at Leeds Beckett University?
I am, yes.
I think you are a multidisciplinary scientist with more than 25 years researching the transmission of infection in hospitals, and you've worked in neurology as well.
Yes, I have, yes.
Right. You specialise in what is termed interdisciplinary research, and you have particular expertise in the transmission of infectious diseases in hospitals.
Yes.
And you also have particular expertise in ventilation and the behaviour of aerosols in the air, biophysics, and the application of engineering interventions to mitigate the transmission of infection.
Yes, those are all areas of my expertise.
And before entering academia, is it right that you worked as a professional engineer, designing ventilation and air conditioning systems for buildings? And as such, you have knowledge, indeed intimate knowledge, of hospital ventilation systems.
Yes, that was the first part of my career.
All right. I think during the COVID pandemic, you worked and served on the Royal Society Rapid Assistance Modelling the Pandemic Working Group.
I did, yes.
And if it's not clear from what I've just said, you are a research scientist, but not a clinician.
That is absolutely the case.
I think, though, that you know that the inquiry has instructed a trio of experts with clinical background who can help in relation to that matter.
Yes.
All right. Can we take down, please, the screen? Thank you very much. And can we, at the outset, please try to ensure that when giving your evidence and people reading your report understand the language and understand the science about the way that the COVID is transmitted? All right.
Yes.
So we're going to look firstly at the language. And I think, Professor, you may have heard me explain that although obviously we're dealing with SARS-CoV-2, for ease, I'm going to try and just refer to it as COVID-19.
Yes, and I will try and use the same, but I probably will slip into SARS-CoV-2. Please forgive me, but and I'll probably say SARS or SARS-CoV-1 for the other one.
For the other one.
Comes up.
All right. If there's any confusion, we will do our best to clarify.
But I will also talk about the spread of COVID as well.
Thank you.
When we're talking about confusion, Professor Beggs, I was having a conversation with a doctor at the weekend, And of course, the ventilation gets used in two different ways in this context, doesn't it? So you've got the
Yes.
ventilation, which is opening the windows, and you've
Yeah.
got ventilating a patient.
Oh, right, yes, yeah, absolutely. In fact, I've had this happen in my professional life when we've been talking to clinicians and there's been crossed wires. Yes, you ventilate patients who are having problems with breathing in intensive care units and places like that. But in this occasion, we're not talking about that. So I have done work on bits and pieces on that, but in this occasion, we're talking about the ventilation of room spaces like this room here and air movement in rooms.
Thank you.
Thank you. All right. Some basic terminology, please. And it starts, I think, on page 7 of your report. But I want to just ask you about the language that you have used in the report, because I think you are aware there is not necessarily consensus about the terminology. And we're going to just be clear about what you mean by things, and then we'll look about perhaps at what some other people say about the terminology. All right?
Yes.
Can you help us as a general starting point, though? Why does the terminology matter?
Well, the reason it matters is because historically there's been an awful lot of confusion. And if you think about it, most people involved in infectious diseases are either hospital doctors, microbiologists, virologists, or infection control nurses. They're not necessarily, in fact, they're not trained in engineering generally. And so we've had a kind of two parallel universes come up with one group of people who are on the clinical side of things and mostly in the medical and the infection prevention and control, which I'm going to call IPC after that, who have gone down one route and used one set of terminology, whereas those working in physics, engineering and aerosol science, I suppose, have used another terminology. And I'm from that camp, although I cross over into them. So I will use, I'm afraid that's the more correct terminology, by the way, from the physics. So I'm going to go with the physics. So that's, there's been a lot of confusion. That's all I'm saying.
We're going to look at perhaps some of the ways that confusion plays out as we go through your evidence. But can I start with, please, in your report, you use the phrase large droplets. What is a large droplet, please?
Right. First of all, to say droplets, large droplets, I'm using that term here. It's my term for this inquiry because people, especially from a lay background, need to know this. We're talking the upper end of things, and they're above 100 microns. That's micrometers. I'll use the term micrometers or microns, the same thing.
Is that the size of the particle?
That's the diameter of the diameter of the particle, but we abbreviate that to 100 microns. And there's a very good reason that we'll explain in a minute.
Yeah,
I'm sure.
Right. So a larger droplet, in your terminology for this report,
is that, yes.
Is a particle greater than 100 microns.
Yes.
All right. And just help the layperson, can we see a micron?
A micron is 1,000th of a millimetre, so we can just about see those 100. It's about the thickness of a hair. I think so. I think I read 50 microns as a thickness of a hair, but it's that type of order of magnitude. Yes, you can actually feel those droplets. You can
feel a larger droplet.
You can feel a larger droplet. When someone coughs on you or something else.
And in a nutshell, help us. How does a larger droplet behave once it's in the air? Right.
So, from an engineering point of view and physics point of view, it behaves ballistically, and that means ballistic means it's got some mass, it's got weight, and when you throw it, so it's like throwing a stone. So it has a trajectory. So it's got some velocity and mass, and if we're talking in the context of respiratory aerosols, someone's exhaled it, either coughed it or whatever, these are so large that they will fall rapidly to the floor, and they can't go more than about a metre and a half before they hit the floor. There's something to do with evaporation, but I'm sure we'll come on to that later.
All right, so the larger droplets behave ballistically, either they go
so ballistically, like a stone being thrown, that's the way to look at it. They've got a trajectory.
Aerosol particles, please.
Yeah.
How have you defined them in your report?
I've defined them and used the general understanding, which has been around since the 1930s, really, in engineering and physics, with relation to the respiratory particles. They're the particles that are less than 100 microns. Any particle of that size in this context is that. There's not a strict actual, any demarcation for aerosols. It's the definitions to do with the behaviour and the characteristics. I'm sure we'll talk about that in a minute.
You told us how the larger droplets behaved. What about the aerosol particles? How do they behave in air?
Right, so the aerosol particles, just to reiterate, are below 100 microns, right? And they can be of various sizes down to very small sizes. The thing about an aerosol, by definition, an aerosol is a suspension, a mixture of particles, and they can be liquid or solid or a bit of both, which is what you have with respiratory particles, in air, in a gas, in air. And the really key thing is they float, they're suspended, they're floating in the air. And the really important point is that they take on the air is a fluid, actually. You don't think of it like that, but it is. It flows. They take on the fluid mechanics, the fluid dynamics of the overall fluid. So, in other words, wherever the air goes, the particles go if they're an aerosol. That's the definition. Right?
So in short, they float. They
float in the air while they're in that air, and therefore you can be interchangeable. Anything that's aerosol transmission is airborne transmission. Right. The two are the same.
Pause there. We have a stenographer who is taking a note, and you're also covering some quite complicated. Yeah. So I just want to try and break the answers down a little, if I may, and perhaps give slightly shorter answers, and then we can ask for more information if it helps.
Absolutely.
So, larger droplets behave ballistically. They are 100 microns or greater. Aerosol particles are less than 100, and they float in the air, in short.
Yes.
Right, okay. You spoke about the 100 microns being effectively the dividing line between larger droplets and aerosols. Is that a general agreement about that dividing line at 100 microns?
This is where the historical confusion comes in. Amongst physicists and people from my background, physicists and engineers, there's a fairly agreement from back in the 1930s when this work was done. Shall I explain why the division is there at 100?
Yes.
Yeah. The reason that's a division is that as soon as when you exhale particles, right, so I'm just going to call them particles, respiratory particles, both aerosols and droplets, they evaporate. There's a lot of water in them, so they immediately start to evaporate, and they shrink down to about a third of their size. And basically, so if they're less than, say, a 90 micron particle, that will end up at 30. In fact, there's very little in that upper range. They're down at 30 and below. However, the particles that are larger than 100, they're so big that what happens is they don't have a chance to evaporate before they hit the ground. So that's why the divide happens. So this lot are kind of going down onto the floor, whereas the ones smaller, they kind of evaporate, and they then are wafting around the room on the air currents, basically, and they're aerosols.
So I think you said there that where you use the phrase respiratory particles, you're using it as a term that covers both the large droplets and the aerosol particles. Is that right?
Yes, and the reason I'm just to clarify that, when writing this report, I had to, as we will go on to explain, there's a lot of confusion. I had to set out a framework, and so it was extremely helpful just to refer to them as respiratory particles, and that's what I'm doing here, referring to them all as that, including everything.
We are going to come on to look at the way in which viral infections are transmitted, and obviously COVID in particular. But I want to just stand back for a moment and just get an overview of where we were at the start of the pandemic and where we are now in 2024. If I ask you now in 2024, how is COVID transmitted, by which route I mean, what's your answer?
My personal answer? and my personal opinion, predominantly by an airborne route.
Right. By an airborne route,
But
by which you mean by aerosol particles?
By aerosol particles, although obviously I'm not excluding other routes as well, and droplets and other things involved, yeah.
So
That's my
it
belief.
transmits via airborne, but it does also transmit via the droplets.
Oh, yes, and contact.
Right, and then we're going to come on to
maybe
contact. All right. In a nutshell, what is contact transmission?
That's where we start to talk about hand-to-hand contact, someone coughing into their hand, shaking hands with someone. And then the other contacts are, for example, you cough, you touch a door handle, something we call a fomite. It's an inanimate object. And then someone else touches that and then touches their mouth or their eye or something. There's a route of solid contacts in.
We'll look at that in a bit more detail, but they're the three predominant routes that are in play for the purposes of transmission.
Yeah, there's some people divide them up into into different names, but
don't worry about that.
Basically, that's what we're talking about: the aerosols, the droplets, and then the contact routes, which include fomite transmission.
So that is, as your opinion of how COVID is transmitted now in 2024. What was your opinion back in 2020 when the pandemic started?
It was airborne.
Fine.
That was my opinion, personally.
And what about those who were advising, preparing papers, preparing IPC guidance? Are you able to tell us what their view was back in 2020 as to how COVID was transmitted?
Not the same as mine. The answer there is, I should have said, sorry, qualified my own belief. I believed it was airborne, but I believed it was likely to be airborne, that there was a strong component. So when I say that, I'm not being exclusive. I'm saying that my belief that it was probably airborne, right? Likely. No, the general belief was that it was by droplets and contact and fomite transmission, that's which we'll come on to.
Right.
That was the general consensus at the beginning of the pandemic, which is why so much emphasis was on washing hands and things like that.
So the position has in fact evolved from droplet being thought of as to be predominant in 2020 to now, certainly by 2024, if not earlier, the role of airborne transmission is now perhaps considered to be different and more important as well.
Yes, the World Health Organization realises now that airborne is, and the CDC, that it makes a significant contribution. There's still argument over which is the predominant route in various quarters, but it's shifted. The consensus has shifted considerably.
Okay. A little bit more background, please, about how respiratory viral infections transmit. And I think you say at your paragraph 14, as is probably obvious, that in order for an infection to spread, the infectious individual must shed virus particles into the environment in such numbers, thought generally to range from several hundred to many thousands, depending on the virus, such that a few eventually reach the target receptors of a susceptible host. Can we put that into perhaps more easily explicable language?
I can easily do that. It's a numbers game, really. So we've got two ways of looking at this, but the first one is a mechanistic thing. This is what we do as engineers and bioengineers. Things have to get from A to B to cause an infection. So you can look at it in terms of the transmission route or routes. Someone's got to produce some virus that's viable, that's going to transmit through the environment somehow. This could be in the air, or it could be on hands or whatever. Then it's got to get to the target, and the targets in this case are receptors, which I'm sure we'll talk about later on.
Pause there. Just help us in relation to COVID. What are the main receptors?
Oh, the main receptor with COVID is ACE2 receptors.
Right.
No,
and where are they in the body?
Predominantly the ones we're most interested in are in the nasal cavity and also in the upper respiratory tract, in the lining of the mouth, throat. But they do go down into the lungs. They're also on the eyes.
Right.
And I'm not so sure, but I think also possibly on the lips as well, maybe there.
So
but yeah,
pausing there, that's in
but
short.
to a lesser extent, you know.
Pausing there, that's in short as to how the virus, COVID, gets into the body, mouth, down the tract, in through the nose or in through the eyes.
Yeah, there's got to be it doesn't do it by magic. Things have to move from one place to the other, and they have to have some kind of vector, some transport. But on top of that, I think you asked me earlier on if this is okay, or should we leave this for later? The numbers game. How
We'll come to the numbers in a
come
minute.
to the numbers
I just want to
later.
set out some basics and then we can descend to the detail as we go through your evidence.
Which, sorry, just to clarify, I think that was in there as well about the hundreds and things like. We'll talk about that later. Yeah.
All right. Can I ask, please, about one of the diagrams in your report? And could we call up, please, page 10 of the report and figure 1, which might help bring this together. I think you've set out there how effectively the virus transmits. You've spoken there about aerosols and droplets, and there's various size of droplets on there. Can you just help us, please? What are we looking at here with the person on the left, the infected person?
This is an excellent diagram, which I use in my own lectures, but is not one I produced. It's from a paper that it sums it up, everything. So just to, if you can see on the far left-hand side, you can see aerosols and droplets, and that basically tells you everything we've said already, the division. And it highlights that the droplets are not really inhalable and they're larger than 100 microns, whereas the aerosols are inhalable. So if we see the infected person,
Yep.
Now we're actually seeing the whole respiratory tract, their lungs and their upper respiratory tract and everything. That's useful for maybe things we want to say later, but at the moment, that's where the infection occurs.
Right, exactly.
Yeah.
Let's just stick with the infected person then. You
Yep.
can see there that we've got their lungs, and indeed you've highlighted, or the figure has highlighted, the alveolar. Is that deep into the lungs, in short?
The alveoli are right at the bottom end, right at the far end of the lungs. That's where the oxygen transfer goes on.
And we go up, effectively, through the bronchial, laryngeal.
Yeah, bronchioles, the larger.
Right,
tubes
into
in
the person's mouth.
Yeah.
They may be sneezing or coughing here, it matters not. And out come the aerosols and the droplets.
Yeah. We basically call the kind of lower respiratory tract is basically anything below where the kind of mouth and nose is,
Right.
down into the lungs.
Thank
and the
you.
upper respiratory tract is up from the larynx upwards. But so this is where all the droplets come from. There's a lot of fluid there, basically, and all that. And even when people are breathing, they're producing aerosols. So I'm sure we'll talk about that later on, but that's where they come from, originate. And if they're infected, there's a virus in there.
Right.
And that's going to come out. And once they leave the mouth or the nose, they're in the room space and in the environment,
Right.
which is the next part.
Pause there.
Yeah.
We can see then that the infected person has coughed or sneezed or exhaled.
Yeah.
And the size of the droplets. And does the arrow pointing down to the bottom or the middle of the page indicate there effectively the ballistic way?
Yes, that's.
Can I finish?
Yep, sorry, my mistake.
All right.
Yeah.
Can we see there the ballistic nature of the droplets falling to the ground?
Yes, we can.
All right. And can we also see there the aerosols, the smaller dots on the screen, floating across to the potential host over a distance of about 1 metre, and then potentially going into the receptors on the potential host?
Broadly speaking, yes, you're right. Of various sizes, those aerosols, they're actually going more than 1 metre in this diagram.
Yes, we can see the scale on the bottom.
They can go a lot further than 1 metre, I can assure you.
Thank you.
And they are then going into the receptors in the susceptible person.
All right.
No.
And help us, please. The aerosols, the smaller particles, where do they tend to end up in the potential host?
What happens is that those aerosols are floating in the air. There are various sizes, right? And they are inhaled. If they come in front of the face, they're inhaled through the nose and through the mouth, depending on whether you're mouth breathing or nose breathing. And what actually happens during respiration is you exhale out, and so when you're exhaling out, there's actually a jet of air coming out, and it's blowing away little aerosols. And then when you go inhale, which we call aspiration, we take a breath through the nose. Actually, the air velocities can be quite large. They can be between 10 centimetres to up to 40 centimetres per second. And these capture the aerosols that are in that area. That's both through the mouth or the nose, depending on the rate of breathing, right? And how wide your mouth is. And those capture them, and the air sucks in, and the aerosols go in, and then they impact in various parts. The smaller ones tend to go deep into the lungs, into the lower respiratory tract, whereas the larger particles, over 10 microns, definitely stick around up here.
All right. So we've just looked there at how the infection gets in to the potential host. I just want to ask you this. Where, in relation to COVID, is it your view that infectious particles are generated in the infected person? And if it helps you, I'm at paragraph 26 in your report on page 13.
Well, I think I can probably answer it anyway, but without looking to it, I think I'm just going to go fly blind. The particle sizes, it used to be thought that it didn't matter where the particles were generated. Now we understand that the particle sizes in the aerosols actually reflect where they're generated in the human body. So the smallest particles are actually generated deep in the lungs, because there's a kind of fluid lining to the lungs and something called a technical thing called a film burst when you breathe out. And that's just even in breathing. And you produce these tiny aerosols. And these are kind of like 1-2 microns size. They're really small. The other place where you get smaller aerosols are often around the vocal cords there as well. They produce small, slightly bigger, but they're also 5 micron, maybe below 10 micron. They can be a range of sizes. So the fluid there. The largest particles are generated in the actual mouth, and they're saliva. That's where the big ones, the over 100 microns. So actually the particle size reflects where they're generated, and now we know also that the microbes, if they're bacteria or viruses, in them tend to reflect where they're generated.
So the question I asked you was, where in relation to COVID were the infectious particles generated?
Good question. The answer is not 100% clear-cut, but I would say mostly in the lungs, deep in the lungs, and in the vocal cords. Although you can't exclude that some of the virus might be in the larger droplets as well.
Understood. Thank you very much.
But in the lungs and the vocal cords, those are key areas, as I'm sure we'll talk about later on, with vocalization. Yeah.
Can you help us with whether it's the droplets or the aerosols that are more likely to contain COVID or not? Which of the two?
It's the aerosols that are more likely at this. There's a reason for this, and it goes back to there's a change in thinking. But we'll talk about that, I'm sure, later on when we talk about other stuff.
Now, how one?
It's in the small droplets. Yeah. That's it. Yeah. There's no small aerosols. Yeah. Small aerosols.
Thank you. All right. So deep in the lungs, small aerosols. That's where the COVID
and vocal cords.
And the vocal cords. All right. Thank you. Help us with how people generate the respiratory particles. Obviously, we've breathing. What about coughing or sneezing?
Yeah, right. So let's go from the kind of least violent, the breathing. So people didn't realise this before, but we are emitting, I'll give you a figure, over 100 small aerosols per second in just breathing.
Right.
You can't see them, but every one of us is producing that now, right? So they're not insubstantial. So even with just breathing, you produce thousands of these things and hundreds of thousands of them in an hour. The next level up, talking. You're bringing in the vocal cords now, and they vibrate. They produce aerosols. Off the top of my head, I can't remember the numbers.
Don't worry.
But it's an appreciable increase. But the louder you talk, shouting, more gets produced. So if you're in a loud, noisy situation, you raise your voice, more aerosols. Singing, particularly, lots of aerosols there, nearly up to, I think a figure sticks in my head of about 900 aerosols per second. Then we go to the things that the kind of symptomatic things,
Yes.
coughing and sneezing. Now, they're slightly different in the sense that when you have a cough, and especially a sneeze, you get a violent action. And that brings in the whole of the system, and that strips out more aerosols. So you get a wider range, you get larger droplets produced in those things, and a lot of particles in between. That's how it works.
All right. Can I just touch on evaporation, because you've told us
Yes.
about the respiratory particles being made up of water, which clearly evaporates. And if it helps you, Professor, I'm around paragraph 30 on page 15 of your report. But I think you say this, that no matter what the size, all respiratory particles comprise mainly of water because they're formed in the lungs, throat and mouth. And as soon as the particles exit the mouth or nose and enter drier air, they immediately start to lose water due to evaporation and dramatically shrink in size to about a third of their original diameter. Now, help us with the droplet
yes.
and the aerosols
Yeah.
and how they evaporate.
Right. I've done plenty of modelling of this over the years in my own work. You've got to understand that a small particle has a small mass for a very large surface area. Think of it as small, we're talking balls, and like from, football, the large one, going down to kind of like, marble size or whatever. So the relationship, as you get smaller, the surface area is much greater to the mass. So you evaporate through the surface area. So these poor small aerosols, small particles, they're losing them even faster. So they're going right down. They've got moisture in there. They've also got proteins and other solids in there. So they evaporate down into these things, right? Whereas the larger droplets, they've got a small surface area in comparison to their mass. So the evaporation is less with the larger droplets, hence why they struggle to evaporate before they hit the ground. But generally speaking, the kind of rule of thumb, and that's why to make sense of this, around about a third of their size. That's a good rule of thumb.
So can I just see if I understood this correctly? Is it the case that the aerosols evaporate quickly?
Rapidly, yes.
Right.
But
the larger particles don't evaporate before they hit the floor?
Yeah, simple. That's the general overall thing.
Right.
And the ones that evaporate go to about a third of their size.
Right, understood. But the smaller particles, the ones less than 100 microns, presumably they can become still suspended in the air and float around?
Absolutely, yes. I mean, just to clarify one point, just to give an illustration.
Please do.
If you produce an aerosol, so say you had it doesn't mean that you're 100. It's a whole gradation of things coming out of the mouth. You can have something at 10, something at 20. So if you had a 15 micron particle, that is so small in comparison to its large surface area. It's going to be evaporated down within, a few centimetres from the mouth. It's done its evaporation, and it's a small particle moving around, so it's very rapid.
I think you said in your report at page 16, paragraph 37, that there was historically, many people concluded wrongly, that the vast majority of exhaled viruses would be contained in the larger droplets, which were assumed to travel no further than about 1.5 metres. But over the years, that assumption has been shown to be incorrect.
The answer is yes. Shall I elucidate on that?
Yeah, what I want to try and understand is why that's important for us to be aware of that historical misunderstanding, if that be the right phrase, and how it affects COVID and the transmission of COVID.
It's absolutely fundamental,
All right.
because it's a bit like a house of cards. Once that goes, everything else goes. So it's crucial. That's a crucial and important factor. Can I just elucidate on it?
Please do.
Right, so, it's a perfectly logical position to hold this, by the way. And I used to believe it myself, right? And that was my understanding, so it's reasonable to appreciate this. So when you look at all those droplets and aerosols, all the respiratory particles that come out of the mouth during, let's say, a cough, for example, right? An exhalation event, a cough. So if you added them all together, you would have a bulk of fluid, right? And we know that the virus is in that fluid, right? But actually, if we looked at the quantity of the fluid, if you think about it, the actual volume of the fluid, most of that fluid, kind of 90% of it, is actually in particles that are over 10 microns in diameter. The bulk of the fluid is in the big droplets, right? Which you think, well, what's the point of that? Until you go to the next stage. So where's the virus likely to be? And we thought that the fluid was all the same. And we didn't understand completely that the virus reflected where the sites where they were generated. We thought that it was just evenly distributed through the whole of the fluid. So that meant if most of the fluid was in the large droplets, then most of the virus must be in the large droplets. And so historically, those involved in infection prevention and control and public health, and you will see it as we'll talk in other documents, made the assumption, and many scientific papers made the assumption, that the bulk of the virus was in those large droplets that don't travel very far. Mm-hmm. Now, that is not the case. Right. But that's only been discovered in the last 10 years or so, 10, 12 years, right, as the science improved. But we will, I'm sure, talk about that.
All right. Now, my lady, can I interpose at this point to say this? Professor Beggs has very helpfully, in his report, set out key findings which summarise a number of paragraphs and pages. If anyone is either struggling to follow or wants to kind of have a quick, easy reference guide, the key finding boxes are very helpful in drawing all of this together. So can I just put that advert out there, if I may, in an attempt, I hope, to help anyone who's following online in particular. Now, can I just ask you this, please, Professor? Is there any scenario or situation in which someone could produce a droplet without also generating significant amounts of aerosols?
No.
No. All right. And when we think about COVID, can I ask you, please, about what you've termed virus shedding? And I'm at paragraph 38 in your report on page 17. Just in layman's terms, what's virus shedding? Right.
So in the context of that diagram we've just seen there, yes. So if it's not clear, the latest science is that the bulk of the virus is in the smaller aerosols, right? The under 5 microns. I'm sure we'll mention that later. But that's the case. The bulk of the virus is in the smaller aerosols, not in the big droplets. That's the evidence now. That goes for both influenza and COVID.
All right.
Right. So now, virologists talk about virus shedding. What they're meaning is, this is getting back to the numbers game. It's the quantity of virus that's shed by any route. So this could be, for example, it comes out of somewhere out of the mouth or the nose, but they don't just mean in the aerosols. They mean you can cough in your hands and then touch something. The virus can be wherever it is. So when they talk about virus shedding, they're talking about the number of, rather confusingly, virus particles, which are even smaller, viruses. And these viruses, they look to see, they do it by various means, but anyway, virus shedding is basically just the number of viruses that are just kind of released by an infectious person, by whatever means.
Now, in relation to COVID, obviously there may be a period of time where you are infectious, but you don't know that you are. All right?
Absolutely.
Asymptomatic, as it's sometimes called. There's also the pre-symptomatic period. Help us with those and what you say at paragraph 38, please, in your report.
Absolutely. You've led me nicely to the right point there. Right, to when you come into contact with someone who is infectious, so they may not appear infectious, they may not be coughing. That's what, they may be perfectly all right. They don't realise they're infectious. And that's what we call asymptomatic. They don't show any symptoms, right? But they're still infectious. However, when you meet them, you don't know whether they've not shown any symptoms, but in 2 or 3 days' time, they may get very, very ill and feel really unwell and stay at home. Actually, they're asymptomatic at that time, but they go on to develop symptoms. So we say they are pre-symptomatic. So strictly speaking, asymptomatic refers to people who never show any symptoms, but it's a kind of loose thing. It overlaps with pre-symptomatic. For it's a working term for, it can include pre-symptomatic people. I would use it in that way. So in other words, I would say it is people who appear to have no symptoms and are still infectious.
Right. So that period of time when you don't know you've got it, in short, because you feel all right.
Yeah.
Help us there, please. I think that's when you say in your report that that's when the individual is most contagious.
Yeah, the most contagious period is shortly before they become symptomatic, if they do become symptomatic, and for that 2 to 3 days beforehand, and shortly afterwards, I think is also fair to say, it then starts to subside the infectivity after their symptoms develop. Is that make all right?
Yes, it does. Thank you. So it's a dangerous situation where people are walking around feeling well, but could in fact be transmitting the virus.
Yes.
Right. And I think you said in your report that the virus was able to spread for maybe 2 to 3 days before any symptoms develop. But with COVID, there were variations between the various strains in how long people were incubating the virus for.
Yeah, I think right. So in that paragraph there, I use the term incubation. So incubation is not quite the same as shedding. Incubations from the minute you first get infected. At that point, you're not shedding that much virus because you're not that infected. You are infected, but it hasn't had a chance to replicate in your body. But as it starts to replicate, then you become infectious. So I think the original figure that I've got down here, the figure that sticks in my head is 4 to 7 days. I think that's for the original strain, the Wuhan strain of the.
It's got 4.6 to 6.4 days. 4 to
7 days. So that sticks there. But for the subsequent waves, the Delta, the Omicron, they found the incubation periods were shorter, so it came on quicker. Presumably, then also that would mean that a similar type of period of asymptomatic or pre-symptomatic infection. But I'm not an expert on that, so I'm going to say that I'm on dodgy ground there. But you certainly will have exactly the same. You'll have a pre-symptomatic period where you're not showing symptoms and you're still shedding.
So whatever time you're incubating the virus for, there is a period of time potentially where you are contagious and you don't know you're ill, and therefore may not be wearing a mask, may not be hand washing, may be in close contact with people, all of the ways in which the virus could easily spread.
Yes, and you may be singing, which
Right.
is, not a good situation.
Right. Can I just deal with a few more questions, please, about asymptomatic transmission, and then perhaps we'll take a break if we may, my lady. Thank you. And if it helps you, Professor, can I turn you, please, to page 22 of your report? And your key findings box at the top of that page, maybe the easy way into this. Thank you very much. Maybe the easy way into this few questions. I think you set out there that a third to half of all COVID-19 cases are asymptomatic.
Yeah, my understanding, in fact, it varies by age group. So in children, it's even higher than that, and young people. But in older people and elderly people, it's much less than that. So it kind of balances out. About 30 to 40% is the kind of figures that I see are asymptomatic. Yeah, I think that's reasonable to say.
And then you go on to say there that although asymptomatic transmission of SARS or COVID is a widespread phenomenon, early in the pandemic, it was not known to what extent it occurred. SAGE regularly reported on the gradually strengthening evidence base, and by September 2020, confirmed definitively that it was occurring.
Yeah, it's a really tricky one, this, in the sense that, what do we mean by asymptomatic transmission? Is this people who are asymptomatic all the way through or pre-symptomatic? And that was a blurring line, so it makes it very difficult. But they were aware early, in the SAGE minutes that I've seen, they were discussing it and they were aware that this was a potential problem, but they didn't know the extent to it. And there's a BMJ article, I think, in December of that year, that is saying we still don't know the magnitude of it. But certainly by the minutes of the meeting in September, this was becoming, it was firming up.
Now, I think it's important to point out, isn't it, that asymptomatic infection does not necessarily lead to asymptomatic transmission. Is that correct?
Yes, except for, of course, we've got the problem of pre-symptomatic is asymptomatic at the time, so it's how you define it. So it doesn't always. There is some evidence that some people who never develop symptoms have a lower viral load, so they're less infectious. But of course, that person who you meet at work or whatever, or who doesn't show any symptoms but has COVID, you don't know whether they're pre-symptomatic or asymptomatic. So it's a very blurry boundary. That's what I'm saying.
And finally, there are those key findings. Asymptomatic transmission of COVID accounts for many of the infections acquired in hospitals, and we'll probably hear more of that, my lady, with the IPC trio next week.
I was going to mention that because not being a clinician, and I read the papers and I'm aware of this. I was asked to comment on it, but the clear evidence from what others have reported is that asymptomatic transmission, both amongst healthcare workers and patients, made a major contribution to transmission in hospitals and other healthcare.
And just the final bullet point there before we take our break. You referenced there that there is some evidence that flu can also be transmitted by asymptomatic people who are infectious. Why have you made reference there to flu when predominantly we're talking about COVID?
Right, well, throughout this, I was given a brief to look at transmission of infection, and you can't if you're looking at pandemic preparedness, it was all around influenza. Influenza, and I would also put RSV, and another respiratory infection, the mechanisms of transmission were all very similar. The viral agent's different, so it makes sense to look at them. So I have looked also at influenza. I was asked to look at influenza, and as I was doing that, I was asked by the inquiry to look at the asymptomatic transmission of influenza, which I have to confess I'd never looked at. And so I dug down into the information. So I don't claim to be an expert on asymptomatic transmission of influenza, but I looked into the evidence base. And it was interesting because there was some contrasting views, but the overall consensus was that, yes, it does occur, but not to the extent as with COVID. Right? So that's why I looked at it.
Is that the point there perhaps being made that if the planning was based about flu and flu could transmit asymptomatically, those that were looking at COVID and drawing parallels with the flu planning might therefore have thought more quickly, well, asymptomatic transmission could also be a route in relation to COVID?
That is a very, very obvious, and logical and reasonable stance to take. I think, you know, when I looked at the evidence for asymptomatic transmission of influenza, I very quickly dug up papers that were showing quite large, similar types of levels to COVID. And then, as I looked at them, I suddenly realised there was a large controversy about this, and that some people were criticising the methodology. And when you actually looked at the methodologies and trying to decide what was pre-symptomatic and what's asymptomatic, that's the big problem. It came down to, I figure, I'm sorry, off the top of my head, I can't say, it's in the report, but 15% sticks in my head. But I don't know whether that is the case, right? So without reading it.
When do you say, you said a consensus developed that flu can be asymptomatic? When did that consensus develop, it having been controversial?
Let's just...
very roughly.
It's down in my... I've got it written.
Is it before the pandemic or not?
Oh, yes, before the pandemic.
Okay.
I think it is, anyway.
Well, don't worry, that's...
Sorry, I'm searching through my text here.
May I make a suggestion?
But,
yeah, we take the break and you can confirm after the break.
Yes, I can certainly do that, yeah.
Right, we'll take 10 minutes.
Thank you very much, my lady.
Kerry.
Thank you. Before we had our break, I think, Professor, you were just answering some questions, indeed one from Her Ladyship, about the evidence that flu can be transmitted by asymptomatic, and we left it on a cliffhanger that you were going to go and look it up. So can we turn, please, to paragraph 53 in your report?
Right, well, I said 15%, it was 16%, so I wasn't far off.
I'll let you off.
But I think the first point there is it's not clear-cut by any means. Difficulties are because, frankly, how do you know who's truly asymptomatic and how much is pre-symptomatic? But you can see the dates here. Right at the top, the first sentence, it says most cases of seasonal influenza are thought to be asymptomatic, and that was someone, Hayward, in 2014. However, that's disputed by various people and various things and methodologies and everything. And this comprehensive, so we're down at about line 5 or 6, a comprehensive meta-analysis in 2015 said really that's 16%, and that's Luang in 2015. Right. You know? So it was definitely there. But the key point at the bottom, just to get it over, is, of course, those people, if they're lower infectious and fewer symptoms, they mix more. So whether they were transmitting more depends on not only how ill they were, but also how much they mixed, should we say. Sorry, I've added that on. But
no, don't worry, because I think what I wanted just to try and be clear, and I know this will resonate, my lady, with evidence you've heard, I suspect, in modules 1 and 2. I think there was a pre-pandemic flu strategy in 2011. And we're going to perhaps look at that a little later with Professor Beggs. So there's the underpinning document in 2011, and then these various studies in 2014, 2017, 2015, etc., albeit not consensus on that either, that suggested, though, that flu was thought to be asymptomatic. So we'll just keep that chronology, if we may, in our minds as we go through.
Can I just clarify?
Yes.
What I'm saying here, it was known that some influenza transmission was asymptomatic before the pandemic.
Yeah.
And the dispute was on how many.
How many?
Yeah.
And it was, to do with methodology.
So I can confidently say it was known that some cases of flu are asymptomatic.
All I've reported is what was in the papers, and that's what was said.
Thank you.
The references are all there.
Thank you very much, Professor. New topic, if I may, please. Yep. And in your report, if it helps you, we're at page 24. And I'd like to examine with you, please, the movement of infectious particles through the air. Now, we've probably touched on it a little bit by looking at the ballistic way that the droplets behave in contrast to the way that the aerosols float through the air. My paraphrasing, I appreciate. But there we have, I hope, at the top, a little summary of that. The exhaled respiratory droplets greater than 100 microns behave ballistically, fall to the floor. The smaller particles shrink due to evaporation, as we've looked at, and become even smaller aerosol particles which can float in the air. Now, help us, please. You say these small aerosol particles can take many minutes, even hours, to settle out of the air, and therefore can be transported long distances around the rooms by air currents.
Can I direct you, can we put it up, direct you to table 1 in paragraph 59?
Yes, I'm going to come on to that, but if it helps you to answer the questions, please do, because what I really wanted to know was, how long does it take? How far can they go?
That's what I was going to do.
All right.
That's why and the table would be, that's it, thank you. Right. Back in 1851, a guy called Stokes developed a whole load of laws to do with, basically it was understood how aerosols behave, right, and how particles in air behave. And we use them in engineering to predict how aerosols behave. And basically Stokes's law can be applied both to moving particles but also to particles in still air. And here what we have here is a table for various sizes, and I just did it for illustrative purposes, a range of sizes. And I'm assuming 2 meters, which is the height of a tall person producing, but it's an approximate height. And you can see there that, say we take a 5 micron particle,
Yep.
that actually descends at about, it takes 32 minutes to fall to the floor.
Right. So
And-
if someone were 2 metres tall,
Yeah, it's a bit higher
Exhaled.
height of a thing.
yeah.
32 minutes, right? So we can set the clock and we can wait till past and it's still falling. And that's in an absolutely still room. This room and every other room that you'll be in has movement, because basically if we have a mechanical ventilation system, we've got lots of movements in here, but when people walk around, and we're each producing what's called a thermal plume, because we're warm,
Right.
and we have a convective current. So there's lots of air movement. So they will stay airborne for a lot longer than this.
Can I just interrupt to say the transcriber's software has crashed, but they'll catch up on the transcriber.
Thank you. Thank you very much. So you mentioned there the thermal plume. Help us. Where is it? What is it? How does it work?
All right, yeah, it's been overlooked a lot. Thermal plume, basically your skin is at about, 36, 37 degrees. The air's at 20 degrees. When it comes into contact with you, you're warm, and every one of us here has got a rising current of air, convective current of air, passes over the face, round the back of the head, and you've got a big plume, and we can actually visualise this.
Pause there, because there may be a diagram that helps you. Could I call up, please, figure 7 on page 26 of the report? Because I think this will demonstrate what you're... So there's a person at the bottom.
Yeah, this is my colleague at Queen Mary's in London.
And the halo, for want of a better phrase, is that the thermal plume?
It is,
you're
yeah.
describing?
What we did there, this is something called Schlieren photography, which is a very specialist type of photography, which is useful in this situation. The horizontal line, by the way, in this particular, is us trying to simulate a ceiling. Right?
Okay.
So what actually happens, and we've got a video of this online, you can see that we have this constant flow of streams of air going up. They get to the ceiling and then they spill out across the ceiling, depending on the height of the ceiling, of course. And you can see it really is quite, they can be kind of moving at the highest above the head at about 30 centimetres, a foot a second. And that can transport quite large aerosols up. What we think is happening, anything that gets entrained into that goes up to the ceiling, then fans out, and then after a while it gets slowed down and the heavy particles fall out. But it can also go for radiators. In rooms, they can do the same thing. It's an area that's not really... It's the big difference between indoor transmission and outdoor transmission. It's one of the key differences.
Right.
Outdoors, it just goes up and is distributed.
Right. So the virus can go up in the particles, upwards through the thermal plume, and then into presumably any current of air that is within the room.
Well, in fact, here we've got what we call four-ways louver diffusers. They're something called a Coanda effect. They're shooting air underneath the ceiling. So if someone's producing a thermal plume that then mixes with that and there's particles in it, they will be distributed around. So this idea, it's very complex. It's complex fluid mechanics, and it's different in every space. But this idea that we can just say a particle falls out of the air very quickly, by its size, it depends what it comes into contact with. And this is the problem.
Can I see if I understand this correctly? Your thermal plume sitting there will travel upwards, and on a current, could flow in the direction of Her Ladyship, me, everyone else?
It could do.
Right.
Obviously, the smaller particle, the heavier the particle, the point about the aerosol is that it will only, the particles will only stay suspended in the air until the air current drops in its strength, at which point they start to descend, but they then fall into the next air. They kind of do that, but they go a lot further. So the table in Table 1 is an ideal situation in still air.
Yeah.
And unfortunately, I've seen in lots of literature people saying the worst case is they say like a 5 micron particle can't go more than a metre, which is just wrong. But people sometimes take a value off here, but rooms are not still.
Yeah.
That's the whole point. That's the bit that I'm trying to get over.
Are you able to help us with how far, in metres or whatever metric you wish to use, an aerosol can travel? In a room like this, perhaps, might be the easy way of thinking about it.
Yeah, they can travel a long way, much further than 2 metres, right? That's from the social distancing point of view, and where we'll talk about near field and far field. If we could look at figure 8, please.
I thought you were going to turn to that.
Yeah,
My lady, it's behind tab 8, and it is INQ 497038. This is going to be, when we get it on screen, there we are.
Oh, right. That's I didn't think that was figure 8 actually, but it doesn't matter. This is good as
Just
well.
deal with this. Well, this one is in the context of 6-bedded
very
bay.
good. Figure 8 in the report was actually also computational fluid dynamics. CFD stands for computational fluid dynamics, and it's a tool that we use, physicists and engineers use, to simulate complex flows of air and particles and fluids in various environments. And this is actually work that we had done at Addenbrooke's. I worked with Addenbrooke's team there at Addenbrooke's Hospital, and this simulator is one of the wards there, where you have a classic 6-bedded bay. And what happens is we used a team of aerodynamicists used computational fluid dynamics to simulate the transmission of aerosol particles. And there we have a bed, the dark bed on the right-hand side in the middle of the 6-bedded bay is a patient who's infectious. We can't see the thermal plume here. They're lying in bed, they're exhaling out. And this is actually 2.5 micron particles. And we built in the thermal plume. And what you see is the density of the particles after 10 minutes in that space of regular breathing out and exhaling particles. And you can see them migrating all the way through. And in fact, as part of the studies that we did at Addenbrooke's, we looked at the particles, and we could see them migrating throughout the whole ward within minutes. Yeah, it takes time. That's what I'm trying to say. They can transmit 10 metres easily. You know?
And so, although this is a simulation of a 6-bedded bay, one can see there that not only is there the infection concentrated around the infectious patient, but the 2 beds either side of the infectious patient, and indeed the aerosol beginning to spread out to the other 3 patients and up to the top of the bay.
Into the corridor. That's the corridor towards the nurse's station. Sorry, you said a simulation there. This is a simulation.
Yes.
But in fact, just to clarify that, that we also did measurements. We had particle counters throughout the whole ward. Now, these are not looking at bioaerosols. They're just looking at particulates throughout the whole ward. And in an earlier study, we actually measured the transport, and we published this in the Journal of Hospital Infection. And what we found was, for example, when the ward round came round, we saw the particles go up in one part of the ward, 10, 15 metres away at the far end, and then those particles just migrated all the way through, as with the ward round as the doctors went round, but also as the air currents moved, which is exactly what we're seeing here.
Thank you.
So it's not just simulation.
No, understood. Perhaps we just take that diagram down, please, because it brings me on to inhalation and the risk of inhalation. And if it helps you, Professor, I'm at paragraph 65 onwards in your report, which is at page 28.
Yeah.
I'll just give you a moment to turn that up. It's probably evident, just looking at the key findings first of all, that when aerosols are inhaled, the different sized particles land in different places within the respiratory system. All right? And the smallest particles, which, as you told us before the break, are more likely to contain the virus, they tend to travel deep into the lungs, while the larger aerosol particles land in the mouth and throat.
Yes. But yeah.
Did you want to add a caveat to that?
Yeah. There's no clear cut-off, right? So historically, the kind of, which comes back from almost the end of the Spanish flu in the First World War, the early part of the 20th century. So it's pretty old science. But it was realised then that particles that were less than 5 microns tended to travel into the lower respiratory tract. What that means is that they went deep into the lungs. Particles above that size that were inhaled tended to stick in the nasal cavity in the upper respiratory tract. And clinicians used that as a demarcation to do with TB. TB went down in the lungs. They thought that was small microns, whereas things like influenza, which predominantly infects the upper respiratory tract, first and foremost, they thought, well, that must be in particles bigger than 5 microns. And we'll come on to that later. But the truth of the matter is it's a gradation. It's roughly around there, but it's kind of 10 to 5 microns. 10 microns can go deeper into the lungs as well. And some 5 microns can stay up in the upper respiratory tract. But the important point there is that particles in inhalation up to 100 microns can be inhaled if the air is strong enough if they're in the region. They can, but they don't go deep. They just stay up here.
Right.
But most of the particles that are being inhaled and tend to end up somewhere in the system are under 20 microns. That's the general rule. But it's not hard and fast.
No, understood. All right. Now, I think you said, though, in your report at paragraph 66, that aerosol particles tend to be light and slow-moving, and as such are easily inhaled.
Yes.
If a susceptible person is close to the infectious person, then there is the potential for the droplets via the eyes or the mucous membranes in the mouth and nose. Is that correct?
Yeah. Yes. I'm just trying to see this. Yeah. So this is about droplet transmission, the larger droplets, right? So, yeah. So we're talking about larger than 100 microns. They can't travel very far. So if someone's in close proximity to someone else, within a metre, say, and someone coughs or sneezes and they're infectious, they're going to produce a whole load of aerosols and droplets. But those droplets have got a trajectory and they're ballistic and they can land, we all know it, we've all experienced it when someone's coughed or spoken and you can feel the spit, on your forehead. That's a very large droplet. But they could land on your eye, and there's some ACE2 receptors there, or sialic receptors with influenza, and that could cause an infection, a route of what we call a portal of entry. Or, and it's a bit more ambiguous on this one, it could land on your lips, for example. It could land on that's trickier. In my opinion, it's trickier, but traditionally it's thought on the nose.
Pausing there, if we just think about
it... That's the droplet,
understood.
Not the aerosol.
I know. If we just pause there and I think about it in the context of a nurse taking a vital sign, blood pressure or temperature in the ear, essentially what you're saying there is that the droplet, the larger particle, can easily, if they're up close to them, end up in the eye or in the mouth, albeit that you're less... Absolutely.
Well, I personally find it harder to see how it gets up the nose, because what's happening is these droplets are tending to fall away, and they're large, so they can't really be inhaled very easily. So they're moving away, they've got momentum, so they're not being drawn in, but certainly on the eyes. But they could land on the lips.
So if the nurse...
Maybe on the nose, and someone could touch them and then pass it on, rub their eye or something. So
if the nurse is not wearing a goggle or a visor, that's an easy route.
That's an easy route for that. I've got to say, it's a route, but the epidemiology supporting this is not actually that strong, because when I looked at it, this is what is supposed to happen. And it's plausible, definitely.
Now, let's look at the aerosol particles and your paragraph 67, and you say that because they are suspended in the air, the quantity that will be inhaled is directly proportional to the concentration of the particles in the air and the volume of the air that is inhaled. So take a slightly different example now. The nurse is not taking blood pressure or the temperature, but is on the other side of the room dealing with another patient. Help us, please, with what you say there and the level of risk to the nurse.
Yes, I will, but I want to just say one thing in relation, because it's important to do this. So let's make the nurse, again, taking blood pressure in the same position as the droplet. You can't have droplets without aerosols. So if that nurse has got no mask on, for example, they may receive a droplet in the eye. It's a fairly small target, but they're more likely to get a face full of aerosols and inhale those into their things. In my opinion, that's a higher likelihood. So in that near field, they can get that. But of course, aerosols don't just stop there. They pass on further. So now we go to the longer range thing that you've just described. So,
well, we're going to look at near field and far field. So it may be as well to deal with it now.
Right. So going back to the concentration of the particles, it's irrespective from the aerosol point of view of whether it's in the near field or the far field, near or further away. You breathe in some air which has some virus in it, viral particles. So it's actually just the number of viral particles is the risk is related to this is the numbers game. The more viral particles you inhale, the more likelihood that one's going to hit one of those receptors and cause the infection. So it's to do with the volume of air inhaled, wherever you are in the room, and the concentration of particles in that. And obviously, if you're close up, the concentration is likely to be greater than if you're further away. And the volume of air inhaled, that's the total volume, depends on how fast you're breathing, how much you take in, but also how long you are. So we now have... As in how long you are exposed? Exposed.
Right. Can we hive that off, if we may, and deal with that slightly separately?
The volume and the concentration changes where you are in the space, but it's dependent also on how much air you breathe in, and that's dependent on time.
So can I see if I understand?
Can I just interrupt? I know how careful you're trying to be and and it really is very helpful information. But Miss Carey's an expert at getting what she needs and what I'm going to need. So if you could just try and shorten your answers, and if she wants more, she'll ask for more.
I will, yes, sir.
Because we have limited time. I'm sorry to have to.
No, that's okay. It's very understandable.
No, so thank you, my lady. Can I ask you, see if I understand this correctly from your report? If the susceptible individual spends 2 hours in the room as an infectious person, they're going to be at much greater risk of acquiring the infection compared with someone who's only in there for 5 minutes?
Yes.
All else being equal?
All else being equal, yes.
But of course, one's got to bear in mind then how close you are to the infectious person.
Yes. So you... All right.
Go on, no, you can carry on.
So we could have, for example, someone who is close to a person for a short period of time, inhaling a certain infectious dose. They've got a high concentration, but they take it in for a short time. Or in a cafe, for example, or someone on the other side of the cafe is working there for 4 hours, or with their computer, and they're breathing in infectious air. They're breathing in a smaller concentration, but for longer, and so they can actually get the same infectious dose, actually a greater infectious dose, even though the concentration is lower in the far field.
So for the infection to occur, is this right? You need to have inhaled a respiratory aerosol that contains the virus?
Yes.
The aerosol must come into contact with a receptor, nose, mouth.
Wherever?
Yeah.
Yeah.
The virus in the aerosol must be fit enough to bind onto the receptor.
Yeah, it's got to be viable to get in, and there's got to be enough of it to get into it, basically, yeah.
And then once inside the receptor or the cell, the virus must overcome any of our own immune system in order for the infection to take hold.
Yes, so what actually happens is that most virus particles either miss receptors or get knocked out by the host defences, or not fit enough, and it's just that few that get through.
Right.
It's a numbers game.
So Does that generally mean, therefore, that a large number of virus particles need to be inhaled in order for an infection to be established?
The figure that sticks in my head from I think it's the Skagit Choir analysis, or is it, that's another paper, is 600, I think, in this particular case, for a kind of ratio of 600 to 1,
Right.
the expected dose to be inhaled. But that again is an estimate
Right.
that's in.
But in short, you've got to get a large number.
You've got to get a large
in order
number,
to
but that
get
is
it.
always the case with viruses, you know.
Okay. All right. And if I understand your evidence correctly, therefore exposure time and concentration of the virus in the air are critical when we're looking at how the infection gets in and spreads.
Absolutely, yes. The longer you spend in a space,
Yeah.
even if the concentration is not that high, you're at risk.
Can I ask you about an example that you refer to in your report, please, at paragraph 74
Yep.
on page 30 of your report, which might highlight the importance of exposure time and indeed concentration of the virus in the air.
Which was it? Yeah.
It's
Yes, I've got it, yeah.
Yes. I think you looked there in situations where the viral load is allowed to accumulate in the
Yeah.
air, let's say in a poorly ventilated room.
Yes, right.
Even short exposure times can result in significant risk.
Yeah.
Especially, let me just finish, and then this is especially in the case where individuals may be shouting, singing, or just talking, and then you go on to refer to a study by Alsford.
Yeah.
Help us with this paragraph, please.
Yes, no problem. Right, so two things happen really when you exhale a virus, exhale aerosols which contain virus. So you imagine someone in the near field, they're going to get a waft of this thing through past them. It goes
Pausing there, near field 1 to 2 metres, roughly?
1 to 2 metres, yeah. I call it, yeah, that kind of region. They'll get the first waft, which is a high concentration, and that could occur indoors or outdoors, right? But those aerosols then, assuming they're not inhaled, progress into the room and mix, and then the air currents in the room take them around. And this is where it differs from indoors and outdoors. So outdoors, there's a progressive dilution. But what happens indoors is, because we've got an enclosed space, these aerosols start to waft around and build up in concentration in the space. So someone in the far field who's some distance from the infected person, they can be breathing a kind of soup of aerosols, if the virus is in there, if it's a poorly ventilated space, of a fairly high concentration over quite a long period of time. And it's made even worse if you're in an environment like the Skagit Choir, which we may come on to later, where people were singing, if it's noisy, a nightclub or a church or something, where lots of super spreading events have occurred, where we have generally got people raising their voices. Singing is a classic one.
Yeah.
And so they're producing lots of aerosols into the space, and the concentration builds up and everyone's breathing it in. And in that situation, Alsford calculated quite a short period of time, even within 37 minutes. It depended on the ventilation rate and all the rest of it.
So is it fair to say that healthcare workers treating patients who are generally in the near field, in that 1 to 2 metre range, or potentially right up close to them, are more generally exposed to the near field risk?
In that specific situation, yes and no. They're in the near field risk when they're treating that patient and caring for that patient. They're in the far field risk when they're at the nurse's station, or it's a cleaner or someone who's working around about. And other patients may be in the near and the far field, depending on the situation.
It's not just nurses, non-clinical staff like the cleaners, the porters, someone
Non-clinical staff are also exposed to it in offices and hospitals and things like that as well.
And I think you said in your report, I won't take you to it, Professor, but you said that when considering the near field, direction is important. Clearly, face-to-face poses more of a risk.
Yeah.
Side to side, a risk, but not as
Yeah,
much as face-to-face.
near field, definitely, if you're in front of that, what we call the exhalation plume, you're going to get a higher dose. Actually, there is a slight caveat to that in the clinical scenario, because patients are often in bed, and so the thermal plume rises up from them, as their exhalation does as well. And so clinical staff are often above the patient. So I would include both the exhalation plume and the thermal plume. So if you've got a patient, you're taking blood pressure or something, they're lying down, you can be leaning over them and getting both the exhalation and the thermal plume. So,
Right,
yeah.
understood. There's a number of variables there as to how you end up getting infected, but can I look at a different form of transmission now briefly and come on to what you've termed fomite and contact transmission? And it's at page 36 in your report, Professor. And again, terminology may be important here. And so actually, thank you. The key findings may be a helpful way in to this evidence. I think you said in your report that historically flu and other respiratory viruses have been assumed to be transmitted by droplet transmission, the larger particles, and by contact.
Yes.
All right.
And fomite as a
Now,
subgroup.
yes, there's direct contact, indirect contact, and there's also the phrase fomite. So let's deal with those, if we may, please. Can I just deal with contact? Direct contacts. Help us, please. What is meant by the phrase direct contact? And if it helps you, it's paragraph 91 on page 37.
Yeah, right. So I'm not actually saying contact. I'm talking about direct routes and
Yeah.
indirect routes there. And it's important in the thing. So shall I explain?
Yes, please do.
I was asked by the inquiry to examine all the routes, right? And I have done quite a bit on hand washing and in my time, but mostly in things like MRSA. So I wanted to set it alongside the airborne and the droplet as well. So we're looking at the whole picture, because it's really important that the number of intermediary steps, the virus can get diluted, basically, right? So I wanted to talk about direct routes. In this report, it's confusing because they talk about direct contact and indirect contact. So I'm talking about direct routes in this report and in this paragraph as meaning there's no intermediary stage. So that could be a droplet going from coughing and landing on someone's eye, or it could be an aerosol going out, flowing round and going up someone's nose.
Right. So
that's direct.
Pause.
Yep.
Thank you. I just want to make sure I understand that right. The virus travels from the infected person to the receptor without touching anything in between.
Yeah. So whatever is in the virus that left the mouth, and we're talking in those situations, certainly in the near field, within seconds in the case of the droplet, within minutes. So there's nothing in the way to interfere.
Understood. Indirect may be obvious now, but help us please, looking at paragraph 91, I think you said that indirect routes involve one or more intermediary steps.
Yes.
So in the context of respiratory transmission, help us with that, please.
Well, it's difficult. I suppose that could be with the intermediary step there, is the droplet when it lands on the outside of the nose and someone touches it and then rubs their eye. That would be an intermediary step.
Or a droplet falls onto a bed handle, on a patient's bed.
Classic. There's a bed rail or it drops onto a surface, a patient's surface, so the patient does that, or onto a medical instrument or something.
Understood.
The nurse touches it and then rubs their eye, for example, or whatever.
So there's contamination effectively via some kind of intermediary surface.
An intermediary step, right. and the classic one is the handshake is that.
Well, I wanted to ask you about that because handshaking is sometimes given as an example of direct. But if I understand you correctly, it isn't, because it's got to go onto my hand I shake the other person's hand, and they then have to
Yeah.
transmit it to a receptor. Is that right?
Yes. In the textbooks, when they're talking about hand contact, they say that's the direct route. I'm doing this for this report because I'm trying to make sense for everybody's, that there are intermediary steps, and that's really rather important. So the direct contact, say, touching someone's hand or touching something, I suppose if someone kissed someone, that could be a very direct route, but that's a very, intimate. I don't know where to go with that one, really. But we'll leave that at this moment.
Yeah.
But I'm blushing now at this. I can see this here.
I don't think kissing got banned. Did it?
I don't know. Well, what happened in the home stays in the home, I suppose. Yeah. But the point is, it's the idea. The classic of the textbooks would say the classic of the indirect and two indirect routes, as I've classified here. With the hands, the classic one would be, hello, you cough into your hand, you shake hands with someone else, they then take it and they rub their eye or their nose or something. Or with the fomite, that would be, you cough into your hand, you touch the door handle, you walk away, someone else then touches the door handle, then they do that.
So that is what is meant by fomite?
That's fomite, yes.
And can I take it that where you're dealing with indirect transmission, viral material is lost through degradation?
Yes, every time you touch those. So let's take the door handle. That's a great one to do. So even when you cough and you cover your hands, not all the virus went onto your hands.
Yep.
And the hands actually aren't very good at porous surfaces, and hands tend to kill the virus. They doesn't last for very long. So whatever goes onto the hands then has to be transferred to it's lost something there, goes to the door handle, it's lost some more, and then the next person to touch the door handle doesn't necessarily touch them straight away. They might wait an hour.
Yeah.
And in that time, it's degraded over time. The then person touches it, it loses them. And in fact, I think it was Raymond Tellier did some analysis and reckoned that only about 1% of it eventually gets to the target, if it does get to the target. So it really is degraded. And so time is a very key, important thing in there.
Now, clearly, though, when you're talking about direct contact, it goes, you cough in my face, effectively.
Very short.
Yeah, exactly. That's the point.
So the virus is fitter.
Yeah.
And it hasn't been through any intermediary steps.
Okay. So survival time depends on the surfaces, how porous, all of the other ways in which it can
that wasn't
fully told us about.
Fully understood initially, but later on, many studies have shown that the porous and hands and things, it doesn't survive that well on it. But hand washing is really good, by the way. So don't.
Well, that actually was going to bring me on to, I think you said in your report that the fomite transmission, touching the inanimate object, and indeed contact transfer plays a role, but the precise proportion of that is not yet known. Is that correct?
Yes, in my opinion. At the beginning of the pandemic, it was thought to be much more important than later on, but I'm sure clinical witnesses will tell you the same thing. As it went on, it got downplayed, and it certainly the fomite and the contact, and so less emphasis was on that, and more was on the droplet. So I think it does make a contribution, but I don't think we understand how much of a contribution. But I would say it's a significant but minor contribution. Right. That's my personal opinion.
Right. I think you did say in your report at paragraph 105, though, and you made the point that the precise proportion of fomite and contact transmission that plays a role is not known, but the IPC people, by which you mean those drafting the guidance, and public health assumed it to play a greater contribution, whilst airborne certainly initially was considered to be an unlikely.
Yeah, well, I always like to kind of quote higher authorities than myself, right? And the PIP report, which is the Pandemic Influenza Preparedness Report from 2011, there was two of them, and there you see it in 105. It's since the role of hands in the transmission has actually never been demonstrated epidemiologically, one may hesitate to attribute great proportion to this pathway. That was the epidemiological evidence is not that strong, to be honest.
All right. Can I,
for this,
perhaps before we break for lunch, I want to deal with one other topic, if I may, my lady, and it's to look at some of the other terminology that is used, and then perhaps after lunch we can look at some of the historical controversy and assumptions that played out, in particular, in the IPC guidance. So, Professor, can I ask you this? I think you were shown a statement by Lisa Ritchie, and it will be in your bundle behind tab 3. Now, she was the chair of the IPC cell, made up of a number of individuals, and obviously it wasn't proportionate for the inquiry to speak to all of them.
Yep.
And so although she is the front person, I want it to be made abundantly clear that she's often speaking on behalf of the cell's position. Occasionally she speaks to her own position, and we'll deal with that when we hear from her. But can I just ask you about some of the terminology that she uses, whether you agree with it, and see where we end up just before our lunch break? And could you turn, please, to page 13? And if we put it on screen, it's INQ 421939_13. Because we're, I hope, a bit more familiar now with some of the language. And there may be a divergence here. And if we look at droplet transmission, there the statement sets out that droplet transmission involves droplets of 5 microns to about 200 in diameter from another person's, infected person's respiratory tract reaching the eyes, nose, mouth of another person. And then it sets out large droplets greater than 20 microns typically fall to the floor within a metre. And large droplets, she says at the bottom of paragraph 43, fall to the ground within seconds, while smaller droplets, 5 to 20, can stay airborne for several minutes. Now, just pause. You have told us about the distinction between 100 microns, and now we're introducing much smaller figures. And I want to try and understand what you say about droplet transmission, firstly, involving droplets of 5 microns to about 200 microns in diameter. Is that a range of diameter with which you're familiar and with which you would agree?
I disagree with it, but I am familiar with it, if that makes sense. May I just elucidate one thing?
Yes, of course.
Earlier on in your questioning, earlier on in the first session, you asked me about the 100 microns, and I said there was 2 schools of thought, and I went down the engineering physics, which I believe is the correct one because it's dealing with the physics, which is well established and has been established for about 150 years, certainly 100 years in this situation since the 1930s. The other branch is the medics and the IPC branch, and this represents that. And they, we'll see it in the next session, they had this 5 micron demarcation. They didn't actually say 200 microns, but that's a good upper limit, it's not bad. But that 5 microns, they said anything bigger than that was a droplet. So I'm familiar, I've seen this many times in many things, but as far as I'm concerned, that has no basis in physics. It's completely arbitrary, that first statement there. Certainly, they do go up to 200 microns, and they certainly are in the 500 microns, but they're not droplets. Those are below 100, those are aerosols.
Right. So,
but they can reach the eyes and...
Yes, that bit there's no dispute with, but from your evidence, if I understand you correctly, droplet is referring to microns 100 plus.
Yes.
Aerosols lower than 100.
As in that diagram, which we saw earlier on, Wang's diagram.
Do we need to look at the paragraph 43 referencing large droplets greater than 20 microns now being introduced, typically falling to the ground?
It's just not true. It's
right.
not true. In fact, I can tell you what a 25 micron particle, which is larger than that, right? It's factually incorrect. That will take to fall out of the air about 1.3 minutes from a height of a standing height. And remember, that's in still air, not in air. And that has a descending velocity, according to Stokes' law, of 2.5 centimetres per second. Bear in mind that the average air velocity in this room is in the region of 15 to 25 centimetres per second, that type of order. These particles, in those 1 minute, they will travel much further, can potentially travel further than a metre, especially if they're entrained into a
So there is a divergence here between the physicists, if I may put it like that, and the clinicians. And I want to try and understand, why is it important in terms of infection prevention control measures?
Well, if you feel that a particle, so say most particles are in that kind of smaller range, if you feel that they're but above 5 microns, if you think that that's a droplet and doesn't go more than a metre, which is the classic viewpoint, and I'm not saying that's here necessarily said quite like this, but the classic textbook says that a particle greater than 5 microns doesn't go more than a metre. Then if you stand 1.5 metres, 2 metres away, socially distanced, you think, well, all the droplets will fall on the floor, and you're not taking into account the aerosol that will be inhaled, especially both in the near field and in the far field. So you don't think the aerosols are important, basically, especially if you don't believe that the virus is in them, which we now know the virus is in those things. Also, I should say, you would be recommending a surgical mask.
Right.
Because you'd be trying to stop droplets and not being too concerned about the aerosols, if that was the case.
So, do I understand this correctly? The size of the droplet can determine not only how far, the size of the particle can determine not only how far it can go, but the type of IPC measure that might be required by the healthcare worker in terms of masks and other bits of PPE they might need to wear to help protect them.
Yes.
All right. Okay. We briefly turn to the next page in the statement and just deal with airborne. And there set out is for the purposes of Miss Ritchie's statement, what she says about airborne transmission involves the infectious particles in a respirable size range that can remain suspended in the air for long periods and be dispersed by air currents over distances greater than 1 metre.
Right. Can I just say,
Yes.
to clarify, respirable size actually has a strict definition in the well, it's interpreted as less than 5 microns generally. Right. That's the demarcation.
Thank you.
Certainly in the PIP report, that's there. It's the demarcation between the particles that go deeper into the lungs and stay higher up. So 5 microns is generally, it's not stated here, but that would be the kind of size there. Right. So, sorry.
It's all right. So, I'm sorry, I lost my train of thought there. The airborne transmission involves infectious particles in the respirable size range that can remain suspended in the air for long periods and be dispersed by air currents over distances greater than 1. Do you agree with that summary in that paragraph? Or put another way, do you think
Yeah, no, I agree with
reflects-
it, but I would say that particles over 5 microns can also do that as well, can go further than...
Fine. Now, she refers in the statement to short-range transmission and long-range. You've told us about near-field and far-field. So, again, the terminology not necessarily being on all fours. Set out here is short-range aerosol transmission involves tiny respiratory droplets, less than 10 microns, that can spread over short distances less than 2 metres. Do you agree with that?
I disagree with that.
Why?
Right. Because a 10-micron particle in still air will take 8 minutes to drop 2 metres, right, to fall out of the air. So, sorry, 8 minutes, sorry, I should have said, right? So 8 minutes, air can move, and that's in still air, it can move a lot further. So a 10-micron particle, so particles less than 10 microns are going to obviously travel short distances, but they'll travel a lot further than the short distances. Yeah, so I think this says can spread over short distances less than that. The implication being there that it can only travel over less than short distances. No, it can't. It can travel over short distances and long distances. In fact, that's been known about for years. I'm sorry, but,
right.
back in Wells's work in the 1930s on TB, they were talking about, that going.
Long-range transmission, I suspect you've just dealt with. And there is set out at paragraph 49. It's her view that the distinction between a respiratory aerosol and a droplet in terms of size is an academic consideration that cannot usefully be applied in national guidance. Now, can I make it clear, this is not a them and us?
Yeah, I know.
All right, there is a genuine divergence here between the physicists and perhaps the clinicians. So please don't misunderstand that, the position. But I just want you to help us with your view about some of these terms and indeed some of the IPC measures that might flow from the terminology.
Right. Yeah, I will. I'm not trying to do a them and us at all. I'm trying to, really trying to help here. I'm smiling because it just highlights the difference of opinions,
exactly.
Right? Right, so I want to say straight up, I work with clinicians, but I am not a clinician, you know that. But I have utter respect for clinicians, and I see how they deal with patients all the time. And so from an infection prevention control background, which is this person is talking from, they're having to deal with a whole load of practical things. My answer to this is it's not an academic. It's a
Why?
Because it's really important to understand how infection is transmitted, how viruses are transmitted. Because if you want to develop interventions, you need to know how it's transmitted, and you need to know kind of the relative importance of various routes. And then you can develop optimum strategies to minimize that, to mitigate that. And sometimes you might say, we don't have to measure the particles, we don't have to measure the sizes or the things that are put down here. What we need to do is understand it. Then we can take measures that help to mitigate the transmission. That's why it's important to understand. So I don't believe it is an academic issue.
And my lady, may we pause there? I referred to her as Miss Ritchie. She's Dr. Ritchie. I meant no disrespect. I'm sorry about that. But would that be a convenient moment?
Of course. 5-2.
Thank you.
Kerry.
Thank you. Professor, we've got a number of topics to deal with this afternoon, and can I just try and deal with your evidence in relation to the historical controversy? And I suspect we've got a flavour of it already from the evidence that you've already given. But where things are either have gone wrong or have been assumed to be the position, what I really want to understand is what impact that had on IPC guidance and IPC measures. So can I just deal with the first and perhaps one of the main areas of controversy, which is that COVID was not airborne. Now, I gather from all the evidence that you've given that you disagree with that.
Yes.
And indeed believed at the outset that it was airborne, and indeed now in 2024 have firmed up that belief.
Absolutely.
All right. The World Health Organisation's position requires just a moment's examination. In March 2020, is it right that the WHO, World Health Organisation, position on transmission of COVID was that it was not airborne?
Absolutely. They even tweeted about it.
Right. By April 2021, there was partial acceptance by the WHO that COVID was airborne.
Yes.
And it was December 2021 that they stated that COVID-19 could be transmitted via aerosols.
Yes.
All right. Your position is, if I may summarise it, is that by September 2020, and if it helps you, I'm at a paragraph 139 in your report, on page 53.
Yep.
And thank you, it's helpfully highlighted there. You consider that by the weight of the evidence presented, and you set that out in your report, and I won't take you through it, indicates that by the end of September 2020, there was enough moderate certainty evidence to strongly suggest that SARS or COVID could be transmitted by the airborne route. Pause there. The reference in there to enough moderate certainty, is that your terminology?
Yes, it is my terminology. I'm kind of trying to look at it in the whole. I was convinced it was airborne, but if we're looking for, there's a range of evidence from a lot of different angles, which we may go into, I don't know. But I felt that it was a good certainty, moderate certainty. It was not beyond absolute doubt, but it was definitely a strong possibility. That's the kind of thing that I'm...
All right, that's what you were trying to convey there.
That's what I'm trying to convey there. I was convinced, and many of my colleagues from my background would be utterly convinced that it was by that time.
Can I summarise it this way? You thought there were a number of sources that pointed by September 2020 to it being airborne?
Yes, yes.
All right. And that was obviously 15 months or so before the WHO in December 2021 stated that it was transmitted via aerosols. All right.
Yes, yes.
Now, we have alluded this morning to the fact that there has been a shift in the scientific consensus from the position in 2020 by those writing the guidance, those advisors and the like, to where we are in 2024. And do I understand it correctly that you consider that shift in consensus was largely driven by scientists?
Yes.
Okay. And in your report, if you could just take down the insert, I'm not going to go through it.
Distinguishing between, sorry to interrupt, distinguishing between clinicians and your kind of scientist, or are you saying scientists?
It was driven by people from a multidisciplinary background, predominantly very much influenced by people from physics, people like Lydia Maworska, Kath Noakes, engineers, myself and others for that. But there were clinicians involved in that. There was a letter of, I think, about 230 odd eminent scientists, stroke clinicians to the WHO saying, look, it's airborne. And I can't remember the date. I'd have to look at it.
So it was across the board?
Yeah. Thank you very much.
But they were absolutely influential in that.
Underpinning that evolution from the position at the start of the pandemic to at the end, were obviously a number of scientific papers, and you've set them out in your report, and I'm not going to go through them all, save for one that you consider to be of some import in moving the shift towards people accepting airborne transmission. And can I ask you, please, about paragraph 132 in your report? And if we'd like to put it on the screen, there is a summary of it on page 55, and it's the Skagit Valley super spreading event. And on the screen, it's the entry of the 26th of September 2020.
Yeah.
And just in a nutshell, tell us what happened at the Skagit Valley super spreading event and then why you consider it to be so important.
Right. I just want to set it in context, if it's all right,
Yep.
just very briefly.
Briefly, thank you.
Prior to that, right from March, there was evidence that of people sampling the air in hospitals and finding RNA, so that was around. There was evidence from lab work that the virus could stay viable in the air for long periods of time. This is all evidence leading up to that. People had cultured live virus from the air, and people realised that this was in the aerosols and everything. This led up. So the evidence was building. That's what I'm saying. That's why this is all part of the same picture. And this was the kind of icing on the cake. This was when it's a horrendous event, which some of you may know of, which was a choir had a practice in Skagit, the Skagit Valley Chorale, and 61 people were in this practice, and I forget how many hours it was, but it was a number of hours. And I think in a fairly large building as well, a large space. And so they weren't all in close contact with each other. They weren't necessarily socially distanced or anything, as far as I can remember. And 53 of those people became infected. 53 of 61 became infected, and unfortunately 2 people died. And this was reported, first reported, I think, in probably August, but not. The analysis was done with something called the Wells-Riley equation and looking at the whole route of transmission. And the authors came to the absolute conclusion this could not have been by hand contact or droplets. It was far-field aerosol transmission. And that really was epidemiological evidence that confirmed what we had suspected from all the other studies that were coming through.
Fine, and they set out in that little...
So that's why that was a key thing.
I think in addition to the concluding there was overwhelming evidence of long-range or far-field airborne transmission, it perhaps matters not for these purposes, that fomite or ballistic droplet transmission was unlikely to explain a substantial fraction of those 53 cases.
Absolutely.
All right. And you, in your report, said that this study or event gave wider traction to the notion that COVID might be airborne.
Yes, those of us who were working behind the scenes to try and understand this and were convinced it was airborne, this was really helpful because this was further evidence to that.
Right.
But also people were starting to take notice.
Right.
And that's when it gained traction further afield because of that.
And to help root this in the pandemic, this is now probably just before the second wave, my lady. And we're around September 2020, going into the second wave later that year. All right. Now, we just briefly touched on the WHO position. Yep. I want to ask you about the position in the UK, and I think you say at paragraph 140 in your report that Professor Noakes, who my lady heard from, I think in module 2, certainly was aware that from the 14th of April, transmission of COVID might be occurring through the airborne route. And she then went on to form the environmental modelling group. And that group, as my lady knows, produced a number of documents in 2020 and into 2021, which showed the change from COVID-19 is not airborne to COVID-19 is airborne. Is that generally speaking correct?
Yes, that's what I'm saying here. I'm using the COVID is not airborne to COVID is airborne as a vehicle to try and convey the change of consensus.
Just before you move on, you said the pronounce it correctly, Scarget Valley, Coral was September 2020, second wave. When I Googled it, I thought it was March 2020.
Ah, right. Shall I
Can you help? Yes.
Yes, I can clarify. Yeah. The first outbreak was reported in emerging infectious diseases, which is the CDC publication, and it reported the outbreak, but didn't do the analysis.
Oh, I see. So it's the analysis that comes later.
The group, it didn't mention airborne, so a group came together with Professor Noakes, Shelley Miller.
It's right, I don't need to go into more detail.
They
So
did
the event took place in March.
They did the
analysis later.
And did the epidemiological analysis, and this is showing that could not have been highly unlikely to be by the other route.
Thank you for
that takes several months, obviously.
Thank you.
I think I should add that although the environmental modelling group shifted its position from COVID-19 isn't airborne to is, again, I think you set out in your report at paragraph 143, not all scientists agree with that shift. I won't go into that, but it's just to allude to the fact that there isn't always consensus about this.
And it was gradual.
Yeah.
It was in steps.
I suppose really the question comes down to this. Can you help us as to why you think it was assumed at the start of the pandemic that COVID was not airborne? And your paragraph 125 might help you, Professor. It's at page 49 in your report.
125?
Yeah. Essentially, why was it assumed at the beginning that COVID wasn't airborne?
Quite simply, it was assumed it was a droplet-borne was the main route. Droplet-borne don't travel. The large droplets is where it was assumed, in my opinion, wrongly, as it's transpired, that most of the virus was in the large droplets, and these do not travel more than about a metre and a half. Therefore, the only people who can get infected are the people who are in close range. Therefore, it is a droplet-borne. So this, where the virus is in the particles, is hugely important because everything is it's kind of house of cards. Everything rests on that.
Was there any basis for that assumption? I mean, why would you not work on the basis that we don't yet know whether there is transmission?
That's an excellent answer. Excellent question. It's an a priori position. So when you look at this is one of the people don't realise, when you're trying to interpret epidemiological data of outbreaks, and indeed animal experiments, you come at it with an a priori position. You say, does it fit with this or what we expect? And the problem there is that when you actually drill down into the evidence, and it's going back to the 40s and things like this, you can't tell whether the near-field transmission is by droplets or aerosols. It could be either, from the epidemiological and the animal study data. But because you take the a priori position, which seemed reasonable at the time, that most of the virus is going to be in the largest droplets, therefore that would explain that these results would be, it's plausible it's in the large droplets. In the fine aerosols, after all, there's hardly any virus at that time, and the PIP report says that in 2011. That's the justification for the whole thing. They actually set that out quite clearly. Because they assume it's in the large ones, therefore all the epidemiological evidence and all the animal studies are interpreted as being droplet-borne. Then people who come along afterwards, they report it. Yes, it's been shown that it's droplet-borne, but it was all on this assumption. If you flip the assumption, if you knew that they were in the smaller particles, you'd say, well, it was all airborne. And suddenly all the evidence would show it was airborne. So it's an a priori assumption that was reasonable at the time, but in the last 10, 12 years, it's been challenged. But whether people are aware of that.
Well, that's what I'm questioning. Is it reasonable if you don't know the route of transmission, surely you should be preparing for and guarding against. I think some corporate participants have called it the precautionary principle, though I'm wary of that because I've heard it has different meanings to different people. But surely you should be guarding against every possible route of transmission until you know.
You're absolutely correct. I another of my hats is doing statistics, and I spent a lot of time looking at that. And one of the problems with stats is generally with medical statistics, we're trying to eliminate what's called a type 1 error, which is we're trying to say something is. We want absolute proof to show that that drug makes a difference. And we're not so worried about when we get it wrong on the other side, the type 2 error, when we say, basically, which is with the pandemic, it's not airborne and it is airborne. We're not too worried about that generally. But in a pandemic, that's exactly what you don't want. You want to be precautionary. So one of the problems was, I think there was a mindset there that followed through. Sorry, I'm waxing on a bit too much there.
Sorry, it was my fault. I interrupted. Sorry,
Not at all, because in fact that's where I was going to get to, because if in reality there is no clear evidence at the beginning of a pandemic about what route of transmission is adopted, do you think it would be wise for recommendations to cover all modes until you know more?
I certainly would do. And this is one of the big complaints that myself and others have, is that people had a kind of confirmation bias, in the sense they confirmed what they thought and they read that into it. And I'm not saying that there isn't droplet transmission, but to rule it out when, just take the simple fact that you always have aerosols with droplets, and that's been known about for many, many years. If you're going to be precautionary, what you see in many of the randomized controlled trials are people are going to a very high bar of proof to jump over, when in fact, as we've seen, there's very little evidence for the handborne route, and yet they don't apply that high bar of proof for that, because that's the a priori received position. It's in the textbooks and that. So that's one of the weaknesses I see of the whole thing.
Thank you. Can I deal with one other or two other matters in this vein? I think you say at your paragraph 150 that there was an important shift in the thinking concerning vocalisation, i.e. speaking, shouting, singing. I just want to ask you about that. I think you are of the view that breathing and talking was overlooked as a way of producing aerosols. Is that right?
Yes, and I'd include singing as well,
Yeah.
And shouting. If you think about it, all the emphasis, certainly at the beginning of the pandemic, was on symptomatic situations, so coughing and sneezes. You know, people can see people are infectious, distance yourselves, cover your mouth, wash your hands, all the rest of it. But nobody was talking about just being next to someone who's breathing. You know, think about a patient in bed. And if you think about pre-symptomatic patient, say in that 6-bedded bay, an open bay, the other patient's with them, next to them all day long. If that person's infectious and just talking and breathing, they may not be showing any symptoms, but they could still be spreading the virus. So it's a hugely important issue.
One other allied topic is that of aerosol generating procedures, or AGPs. And can I summarise your position? If I've got it wrong, please let me know. But do you consider that the physical science suggests that many so-called AGPs actually produce fewer aerosols than normal activities such as coughing?
Yes.
That's not to say that some AGPs don't produce a lot of aerosols, but there are some on there that actually produce fewer.
I've got to be a bit careful of not being a clinician. But from the evidence that I have seen, and there's been quite serious studies and meta-analysis done, quite a lot of the AGPs, which were thought to produce a lot of aerosols, don't produce that many aerosols.
AGP again?
Aerosol generating.
Aerosol generating. It's a medical procedure. Yeah. So bronchoscopy, for example, would be one where you stick an endoscope down.
I should add, there is not always consensus about what should or shouldn't be on the AGP list. But in general terms, is this the position? There may appear to be an over-concentration on AGPs and the role they play to the detriment of us just talking and breathing.
Yeah. I'll add, if I can add a sentence.
Yes, of course.
Yes, and in my opinion, yes. When you look at the IPC guidelines, the National IPC Manual, there's lots and lots on aerosol generating procedures and nothing on just aerosols produced, natural aerosols produced through exhalation, including coughing actually, and including that, unless it's classified as an airborne disease, and the only things classified as that are measles and TB are the two, yeah, basically.
And just finally on dealing with assumptions, can I ask please that we put up page 45 of Professor Beggs's report? And I hope maybe segue into the pandemic influenza preparedness, the PIP 2011 report. Professor Begg sets out fully in his report the impact of that, but I just want to look at the two final bullet points to bring it together. You consider that the PIP report was well conducted and correctly identified the significant remaining uncertainty about flu, but it has several problems. Unlike many other studies, it did acknowledge the risk of airborne transmission, but only at close range. Does that mean in the near field?
Yes, yes. Yeah.
And made an important flawed assumption about large droplets conferring most of the infection, whereas you are telling us, in fact, it is the aerosols.
Yes, that's that fundamental assumption. And if I may just take a minute, I like this report. I was really pleased that when I read it, they'd gone into depth. They'd justified why things were there. They'd gone through things, and they were looking at it. But they made the assumption that which was definitely prevalent. The first study that actually found influenza virus in small aerosols, less than 5 microns in size, only occurred in 2010, and they spotted that as well. But they made this assumption that most of the virus was in the large droplets, and therefore very little would be in the aerosols. Therefore, aerosol transmission probably wasn't occurring, certainly not in the long range, possibly, however, it might be occurring in the short range, in the near field. That was their assumption. But they did say that the droplet was the main route. There is another flawed assumption, but I think we're dealing with that in the next. Is it in the next one?
I hope so. Can we look at the final bullet point, please?
If not, I will then.
All right. The reason it's important, my lady, is because the PIP report, many of the findings and assumptions in that then underpinned various guidelines for use during a flu pandemic, and by extension, therefore, other respiratory virus pandemics. And it restricted respirators to only staff conducting AGPs on flu patients. You say there newer evidence that large amounts of virus could be naturally exhaled by infectious patients did not shift this initial policy choice during the COVID-19 pandemic.
Right. Before I do that, I don't want to forget the other point, which isn't here, but it's in the text. The other flaw in the PIP report was that they assumed that once aerosols, as they went out, they fanned out and you got less and less concentration. That's what happens outdoors, but indoors, because they're confined, the concentration over time will build up. And so people in the far field, even though the concentration will become more and they can breathe that in, that was just completely missed in the PIP report. So those two assumptions I felt were flaws in that report. Going back to this here, they had raised, what I did like was they raised the possibility that short-range aerosol transmission was occurring for the first time, which I thought was good. But they were mainly concerned about aerosol-generating procedures, as you say, and this is why it influenced future IPC guidance. So it was influential. But there was no epidemiological evidence, as far as I could see, relating to the aerosols in the aerosol generation procedures. I may be wrong, but that I can't really.
That's your position. All right, and I can take that down. And let me just deal with this. I've obviously asked you a number of questions and given examples relating to hospital bays and nurses attending to patients in that context, non-clinical staff going in and cleaning and the like. Can I ask you, what implications does the significance of aerosol transmission have for IPC in smaller settings, clinics, pharmacies, GPs? Is there any difference if we're looking at a smaller setting?
Right. No, the physics is the same, but it's exactly the same principles. Basically, the aerosols will build up in a space that's poorly ventilated. So in a smaller setting, you might be looking at a doctor's waiting room. You might have quite a tight, confined space with maybe not well ventilated, with a lot of people there. You may also find that the same things apply. The longer you spend in the presence of someone who's infected, and the closer you are to them, you're probably going to get a higher load of aerosols.
So across the healthcare settings, it's important to get right at the outset, or at least not get wrong at the outset, the mode of transmission.
Yeah, physics doesn't change whether you're in a big hospital or a little clinic.
Can I move topic completely to face masks, respirators, and to the extent we need to, visors? Now, Professor, we've already seen an example of an FRSM, and if we want one, there is in your report. And I think perhaps if we could call up page 73, and a very helpful diagram there. But in short, FRSMs protect against droplets, is that right?
Yeah, well, it's a fluid-resistant surgical mask.
Fine.
Surgical mask, right?
But they can't prevent inhalation of aerosols due to their loose-fitting...
Yeah, the loose-fitting masks that around the face, they protect the wearer. Well, the first and foremost thing is to actually protect other people by stopping big droplets being exhaled out, so they hit the mask inside and they don't get transmitted to other people. But the aerosols can escape, as you can see in figure 14.
We're going to come on to
we're going to that.
Yeah.
They escape, but they protect the wearer in so much that large droplets heading for the nose or the mouth, but not the eyes, don't hit that. But aerosols can get around the gaps, basically.
And if we look at our figure 14, the first column, A and D, represents the thermal and exhalation plumes produced by someone when no mask is worn and they are sitting quietly. Sorry, A is no mask is worn and D is when the mask is worn. So that's what it looks like if someone is sitting quietly. That's the plume that is produced.
So you can see the thermal plume rising up over them in every case, and you can see, I presume, this person's breathing through their nose, and you can see the plume coming down, for the exhalation plume from the nose going down towards the ground, not even going forward. The next one, B, is where they're actually saying also, and the last one is a laugh, actually, yeah. And then the same thing repeated with the surgical mask on it.
And my lady, that might be a neat way of encapsulating the role that a surgical mask can play in helping either prevent spread of infection or, in the large droplet case, the inhalation of it. Want to say something? Yeah.
Yeah. Can you see how, where the mask is worn, there is aerosols escaping out through around the nose bridge, and you can see how they join into the thermal plume there and then travel wherever, in that sense.
Respirator masks, as we know, are tight-fitting and are therefore designed to protect the wearer from inhaling aerosols.
And they also protect them from pushing them out into the environment as well, but they are designed primarily to protect against all particles, aerosols and droplets.
And my lady's already heard that in the UK we use FFP3 generally, and you have to be fit tested.
They've got head straps that go around the back of the head. That's important because that enables the tight fit to occur.
If a wearer fails a fit test for whatever reason, I think you also say in your report at paragraph 197, but you don't need to call it up, there are respirator hoods that could be used in those circumstances if the fit test fails for whatever reason.
Yes, yeah.
All right. Now, I'd like to ask about the effectiveness of different mask types. Yep. And if it helps you, can we go to, I think, around 210 or page 79 in your report? And I think you say, can we take down paragraph 210 for a moment? Thank you. But in short, is it difficult to evaluate the effectiveness of mask types?
No.
Well,
It depends how you want to evaluate them.
Well, let me deal with some of the detail.
A lab
Perhaps
or
it will.
field trial.
All right, let me deal with some of the detail then. I think you said that demonstrating that masks are actually effective at your paragraph 210, inhibiting the transmission of COVID, has proven to be somewhat challenging.
Yeah, right. I think I just need to clarify this because your question.
All right, clarify away.
Yeah, right. So you can get a mask, put it on a mannequin or in a lab, in a control situation, and you can test the effectiveness. So it's not difficult to do that. So that was my answer to your question. Right. If you want to see how they behave in the real world, do they actually stop a pandemic or stop something, you have to do a trial of some nature. And that is tricky because what happens is things change. You get lack of compliance, you get different rates of infection occurring if you want to do a randomised controlled trial. You can't do a randomised controlled trial because you can't blind it for a start because people know who's wearing the mask. There's a lot of factors. People get vaccinated in the middle of the thing. It gets very difficult to do that type of thing. So it's challenging. That is challenging, the real world thing. The stuff about actually seeing how they behave in the lab, their actual physics of it is relatively straightforward, actually.
It was my fault. It was a bad question. I'm sorry, but thank you for making that clear. There is, however, as you set out in your report at paragraphs 213 and 214 onwards, a findings of a Royal Society review, which conducted, I think, a review of, was it 34 different studies?
Yes, it was, up to Omicron, I think.
Yeah. And I just want to summarise those because they're important.
Yeah.
I think that the Royal Society found that the vast majority of studies they looked at found that masks reduced infection. Is that right?
Yes, they were effective in mitigating and reducing the transmission of infection.
That wearing a mask reduced COVID transmission in the community.
Yes.
And that 7 of the studies found that respirators were more effective than fluid-resistant surgical masks.
Yes.
And that drawing all of the different studies together, the Royal Society found, and perhaps we could highlight paragraph 215, please. There in bold, the Royal Society expert group concluded that the weight of evidence from all of the studies suggests that wearing masks, wearing higher quality masks, bracket respirators, and mask mandates generally reduce the transmission of SARS-CoV-2 COVID infection.
Yeah, I mean, in blunt terms, they found, looking at the overall, the whole thing, and remember, stuff that this was done late on after the pandemic, it's much higher quality evidence than early in the pandemic. They found the weight of evidence was that wearing masks was better than not wearing masks, and respirators were better than surgical masks. That's simple as that, really.
Now, they went on to consider the issue of the specific issue of respirators and surgical masks. And can I call up paragraph 218, please, on page 83? And we can see there the Royal Society review stated there was also evidence, mainly from studies in healthcare settings, that higher quality respirator masks were more effective than the surgical type masks.
Yeah, absolutely. They're the N95 is an American classification, but it's equivalent to a FFP2, actually.
Yeah, which is not generally used in the UK.
Not generally used, but good.
Yeah.
Very good mask. Very good mask stroke respirator as well. Yeah.
So translating that to healthcare settings, I think you said a little lower down in your paragraph 218 that there was good grounds for believing that respirators generally perform better than surgical masks at protecting healthcare workers against COVID?
Yes, yes.
In the similar vein, going on please, in your report to paragraph 221, a number of other studies that you cite in that paragraph, but you say there in bold, are we talking here about a distinction between FFP2 and FFP3 masks? I think we are, so let me let me deal with FFP2.
Let me just have a quick look at this statement and see what it's saying. Yeah.
Right. FFP3 is what is recommended in the UK, although my lady will hear in due course that in the absence of FFP3, because supplies run out, FFP2 was considered to be an acceptable mask in the absence of FFP3.
Yeah.
Right, and so that helps provide some context. Help us, please, with your paragraph 221, though.
Yes. Right, so what I'm saying there is that that first part of that paragraph really should be read in conjunction with paragraph 219. Could I show that, please?
Or just summarise it for us. That's
well, yeah, right. So simply, you can't disentangle masks, face masks, from ventilation. The two are related in the hierarchy of controls, right? And 2019 is building the case here. So here it is here, right? So basically, surgical masks perform better when there's lower levels of pathogens in the air, lower levels of virus in the air. So let me just give you two examples, right? If we had a room with no virus in the air, and we had people wearing surgical masks and people wearing respirators, two groups, you'd find no difference between them because there's no threat, right? You go to the opposite end where you've got loads of virus in the air, you would find that there was a huge difference. The respirators would be really effective because if they're fitting well, but the surgical masks would be ineffective because there's a big super virus out there and they're allowing aerosols to get through. So the effectiveness of surgical masks depends on the viral load, whereas the respirators are kind of immune to that, right? So you've got to look at the load in conjunction with that. So when we come on to 221 now, right? When you're asking me about that, if I can just have it larger, please.
Thank you.
Yeah. That statement where it says this led Chang to conclude that surgicals might provide sufficient protection when exposure levels are low. In virus-rich environments, such as COVID wards, they may not be adequate, right? So in other words, if you've got a situation where you've got a whole load of COVID patients or suspected COVID patients who are maybe even pre-symptomatic or at early stages and highly infectious, gathered together, you've got likely to have a high viral load in the air. Your surgical mask may not be effective against that, whereas if you're dealing with a COVID patient who's maybe just one patient in or a low number, and they're towards the end of their infection and they're not producing as much, the virus in the environment might be less. Therefore, the surgical mask may be more effective in that situation.
So pausing there.
That's what that's about.
So pausing there, in a situation where there is someone dealing with a ward full of either suspected or actually confirmed COVID patients, is that an argument for saying that where there's likely to be such a high viral load, there's a stronger argument for the use of respirators?
Yes, or better quality masks of some nature, but certainly respirators would be a strong argument. Right. In fact, that's what the bold bit at the bottom is there, which was Ferris's study, found that healthcare workers wearing a surgical mask had a 31-fold increased risk of acquiring a ward-based infection, SARS-CoV-2 infection, when working on a COVID ward compared to when working on a no-COVID ward. I think I've got that paraphrased right.
Professor Begg, as a layperson, the conclusion seems to be like common sense.
It is common sense. Sorry, even to a professor of engineering, it is common sense as well.
If you've got loads of it in the room, you need better protection than if you have less of it. Is that what it comes to?
Yeah. But well, it's even in the hierarchy of controls. Yeah, but you'd be amazed that people don't realise that that's one of the challenges when you're doing a trial. You know, how do you know there's the threats there in the first place? You're comparing two groups who wear masks. One might be in a group. You don't think about this. One might be working on a place where there's a real high COVID risk, and the others aren't. It doesn't make a difference. You know, do you see what I mean? This is why it's.
So let me draw some of these. No, not at all. Let me see if I can draw some of these threads together, though, because I think you make the point, and others will doubtless make it, my lady, later in the hearing, that the realities of wearing FFP3 can't be ignored here. They are uncomfortable. They can lead to skin irritation. They are hot.
Yeah.
And after, I suspect, this afternoon's break, I'm going to ask you a little bit about FFP2. But let's just pause there, because you mentioned in that answer that we can't ignore the role of ventilation. And I'd like to just come on to look a little bit of that. Clearly, though, when one is talking about masks, it requires compliance by the wearer. And I think you said that you're aware that in hospitals, infected patients were significant drivers of infection amongst healthcare workers and other patients, and that mask wearing amongst patients, and I'm at your paragraph 206.
Sorry, was that
206, which is on page, if it helps you,
page
78.
Yep.
Mask wearing amongst patients was essential to reduce patient-to-patient or patient-to-healthcare worker transmission, but of course it's difficult to enforce, particularly, for example, if the patient is so unwell they can't tolerate wearing a mask.
Can I just explain that in a bit more in its full entirety, as briefly as possible? So what was found that in the various studies have found is that most of the infection to other patients was from patients who became infected with COVID in hospital, nosocomially infected patients in hospital, and they infected other patients, and they also infected healthcare workers. Right? They drove it. And the reason they did that is because they caught the infection in hospital, and they were there during that incubation period, an early infectious period. That's when they were most infectious. So anyone who came into contact with them was going to be at risk. So they're the kind of key players in terms of driving infection in many situations. So one of the things that my colleague Chris Illingworth and his study at Addenbrooke's was found from his study that it was to encourage inpatients to wear masks. Now this is a big problem because these patients are ill. They're uncomfortable, and they're certainly not talking about, we're talking surgical masks, not respirators or anything. And they're trying to get patients to, I think, according to my clinical colleagues at Addenbrooke's, they were trying to do that, but they kind of ended up all over the place, and it was difficult. Yeah, people have to eat, you know.
Yeah. So if there's a high viral load in the room, one way of preventing you from contracting the infection is mask wearing.
That also helps to keep the viral load down.
I know, but the other way of helping reduce the viral load is therefore ventilation.
Absolutely.
Right. Can we just deal with some terminology in relation to ventilation?
Yep.
Ventilation is the introduction of fresh air to flush away bacteria.
And viruses.
I'm taking your words.
My words, all right.
And viruses.
I obviously was talking about bacteria there.
All right.
Right. Ventilation is this. Yes. It's strictly. It is.
Thank you.
No, ventilation is the action of introducing fresh air, outside air that's clean. To what we do is we dilute the concentration and we flush away the particles in the air. So it flushes away anything that's in the air, because they're as aerosols. So that could be dust, that can be inanimate stuff. It could be bacteria, fungal spores,
understood.
and viruses. Right,
Yeah.
so it's indiscriminate. It flushes it away.
Follow that. I was just trying to let's just concentrate on the virus for these purposes. Air conditioning is the movement of air around or between rooms. It's not the same thing as ventilation, is it?
Air movement is the movement of air around between spaces. So in this room, for example, we could have a ceiling fan. We haven't got one. You'd have to imagine it. It would be moving. You'd feel the air currents generated by that, but that's not ventilating the space. It's promoting movement.
Yeah.
And many people get confused between the two.
Yeah. All right. And air cleaning is the process by which the air is cleaned, as the name suggests, with a filtering unit.
Yes, absolutely. So that does movement. We've got one over there. And
We're going to come on to that.
It's got a fan and air goes through it. So it promotes air movement, but it cleans the air.
All right. Now, can I ask you please to look at paragraph 238 on page 90 of the report. Dealing now with ventilation.
Yep.
Paragraph 238. You say at the top of the paragraph, room ventilation is ineffective against large droplets, i.e. those are greater than 100 microns, because they behave ballistically and drop to the floor.
Right.
Is that correct?
Yes. Sorry, general room ventilation that we normally have. You can have specialist systems that do that, but that's a different animal. But yes, it is correct.
Right. And you go on there to, in that paragraph, make the point that ventilation can only flush away and remove aerosol particles that are suspended in air as these travel with the air currents.
Absolutely. If it's headed for the floor and it's heavier, it's not going to be flushed away.
With respect to this, room ventilation is generally only effective at mitigating the far field infection risk because it can't remove particles in the near field.
Yes, definitely. Again, there are very specialist ventilation systems that can do the near field, but generally speaking, it only affects the far field. It flushes out the particles and reduces the concentration.
And so in IPC terms, room ventilation is a measure designed to mitigate the transmission of disease by the airborne route. Pause, please. Therefore, there is an inherent inconsistency in saying that room ventilation is important while simultaneously arguing that airborne transmission does not occur. This is something that many may fail to appreciate.
Yeah.
Putting that into layman's terms, please.
Yeah, I'm not going to mention anybody. I'm talking in general about things. As what happens is that there's an inherent disconnect between, frankly, you see it all over the place in much of the IPC literature that's been certainly historically, is people generally think ventilation is a good thing, but then they argue that airborne transmission doesn't occur, in which case you'd say, well, if it's all droplet, why on earth we need the air conditioning? Why do we need the ventilation? And, they're contrary positions, and they say, oh, well, it's good to have it. And then, well, if it's good to have ventilation, then you're arguing that there's things in the air and they could be breathed in. So people don't fully connect these, join the dots, if you know what I mean.
I mean, you're never saying you should only have masks or you should only have ventilation. That's not what you're saying.
Certainly I'm not saying that. No, I am saying that I am just saying that there's a disconnect in you need a holistic approach. You need to look at all the routes and you need to have something that's workable.
Now, at your paragraph 240, you set out the ways in which engineers quantify the amount of ventilation required to minimise the risk of airborne transmission. Air changes per hour. And you say there it's the number of complete air changes, so the replacements of air that will occur in 1 hour. Just help us with the example that you set out there.
Yeah, right. So we've got a room here. Let's say we had 2 air changes. Doesn't matter what size the room is. Let's say we had 2 air changes per hour. That's the usual ACH is what that means. Right? 2 air changes per hour. That would mean that the complete volume of the air in the space was replaced twice in an hour. So if we had a particle of air, I know it's a mixture of air, of gases, but if we had a particle of air, that would mean, or an aerosol suspended in that air, one aerosol, right, one viral particle, on average, it would remain in the room for half an hour at maximum, and it would be flushed away.
So 6 air changes an hour
Would mean that
10 minutes?
10 minutes, yes.
Right.
So that's the kind of longest. You can have, that's assuming complete mixing. You can have pockets of air which are stagnant, and that's why we need to look at how that's moving around in the space. But that means that if you've got 6 air changes per hour, generally the particles are not hanging around for a long period in that space, and therefore, if there's a virus in them, that virus is not having a long time to decay. It's not like a door handle or something where it might be sitting there for days.
Right. All right. Fresh air rate per person you set out there is generally specified in terms of litres of fresh air per person per second. And so, for example, in a classroom containing 30 people, if the fresh air rate of 10 litres per second is specified, you need a ventilation rate of 300 litres per second.
Yes.
Right. Now, we won't descend to the arithmetic in a number of circumstances, but that's generally the way.
Yeah, it's just generally, it's very useful in situations, especially where, like this room here, where we've quite a high occupancy level. If you have a lot of people in one space, one's relating to the room, the other's relating to the people.
Now, I think you make the point in your report that a room can have a region of high and low virus concentration. It's not one or the other.
Absolutely. You showed a picture earlier on, which was from a CFD analysis of a ward, and you saw that all the aerosols were down one side of the ward and not the other. So that's because there was a diffuser like this, actually dividing the air and concentrating it in that area, and it was kind of circulating round. So we were getting air movement, and so it meant that certain people were at more at risk than others.
Take another example. There might be a lower concentration by a window that's open than there is at the far end of the room, where you're further away from the window.
Excellent example, because it relates to naturally ventilated spaces. Naturally ventilated spaces are really deep. People don't realise this, but it's a complex fluid mechanics problem. This space is a very, very deep space. We've got some windows. If we were just relying on the windows to produce that, we would have ventilation there, but we could have very still, stagnant regions over here, and it would be difficult. So you can have that, but obviously also where the infector is, you will have likely to have a high concentration. And if you, again, also if you have a strong air current, they might be picked up and deposited somewhere. So understanding how the air moves around wards is quite important, not just specifying the air change rate, in my opinion.
Well, that brings me on to the hospital ventilation guidelines, which start in your report at paragraph 245. And there are what are known as health technical memoranda, which are published. And what do they do in a nutshell, please, Professor?
Yeah, these are basically the guidelines for all NHS estates and hospital engineers and people involved in buildings. They deal with the ventilation, so ventilating hospital buildings, basically. But they're actually healthcare facilities, so it could be clinics as well. And they're called specialist ventilation. The most of the concentrated effort is on things like operating theatres, isolation rooms, negative pressure isolation rooms, bronchoscopy suites, things like that. But they also cover general wards and non-clinical areas, toilets and things like that. Although they're de facto the guidelines that people go to. And there's two of them. One is for the design of them, and the other one, so they specify the air change rates that should be
Fine, understood, thank you.
And the other one is for the maintenance and operations, so validating how they run, ensuring that they're still doing what they're supposed to be doing.
All right. Now, the HTMs, there is HTMs in England, similar ones in Scotland, and I think similar ones in Northern Ireland and Wales. Is that right?
This is where I'm getting a bit iffy. There's certainly in Scotland and England. There are ones. There's something governing that in Northern Ireland and Wales. What they're called, but they're going to be based on the same kind of standards. Again, engineering and physics is much the same, and that's it. Yeah.
Yeah. Now, the HTMs that were in play during much of the pandemic, is that a document from 2007? And I'm looking, if it helps you, at your paragraph 247 on page 92.
Yes.
The current ones.
Yes, no, I can see that. Right, so, yeah, brief history, right? So, at the beginning of the pandemic, it was the 2007 documents that were valid, and they went through until I think, is it June 2021, yeah?
Yep.
When the new guidelines took over. However, the new guidelines were written before the pandemic.
Right. And whether it's the 2007 or the 2021 guidance, they broadly use the same distinction between airborne and non-airborne.
Absolutely, they use exactly the same. They're just slightly modified in various ways, but they, from what I can see, but the key thing is they use a rigid decision tree. Is the infection likely to be airborne, or is it likely to be non-airborne? Droplet is non-airborne, by the way, right? Or contact-borne. And if it's droplet, then it's just an ordinary ward. You don't have specialist ventilation. You don't have negatively pressurised isolation rooms. If it's airborne, then you need negatively pressurised air isolation rooms and various other things. And the only two diseases that are basically classified as being airborne are TB and measles. TB and measles.
Measles, thank you. I misheard you. Thank you very much.
TB and measles are classified. So this classification of whether it's an airborne or droplet is huge in ramifications all the way through the whole thing.
Now, you say at paragraph 249 in your report that the HTMs, the 2021 ones, classify spaces within hospitals as either being areas where the risk of airborne infection is high and therefore specialist ventilation is required, or areas where the airborne infection risk is low and therefore general building ventilation will suffice. Can you just help us? What do you mean by specialist ventilation?
Right, yeah. So let's get this, the risk is high and low, get that out of the way first of all. If it's deemed airborne, then it goes down a certain pathway, right? So if it's airborne, the risk is high, right, by that. If it's deemed droplet, the risk is deemed low, and it goes down a different pathway. So all the specialist stuff kicks in. So there's really a couple of areas where they consider it really important. I'm talking in broad terms here.
Understand.
Yeah. So the classic one is operating theatres, because there's risk of bacterial infections and surgical site infections. So huge amounts of the documents are given over to operating theatres. That's not really relevant for what we're talking about here in the pandemic. The next area is it airborne? Well, if it's an airborne disease like tuberculosis, then the patient should be put in a negatively pressurised isolation facility with a specialist ventilation system that makes sure that there's a foyer, an airlock that prevents the Mycobacterium tuberculosis from escaping into the rest of the hospital. So it protects other people. And then aerosol generating procedures. The classic, forgive me my loss here, but the classic one's a bronchoscopy suite, where we actually do a procedure with an endoscope to actually take biopsies in the lungs. A lot of coughing, classically done with TB, and classically produces lots of aerosols with potentially TB that are infectious. That needs good ventilation. That's specialist. So you see how the pathway goes down that. If it's droplet, you end up on a normal ward, you know. So,
and I think so on a normal ward, that's not to denigrate it, but
I think it's 6 air changes is a specified thing for that.
I'm going to come on to that.
Yeah.
But I think you make the point at paragraph 250 in your report that in general, where you're not dealing with those high-risk areas, such as the operating theatres and the like, in general, areas and wards within healthcare systems, odour control is the main reason for ventilation, not infection and prevention.
Yes, so
Infection prevention.
this is the whole point.
Okay.
They basically say, so if you think about in the light of the IPC hierarchy of controls, it just doesn't even figure. This is just saying that the ventilation there is to stop, get rid of smells, basically. No other real purpose, not for infectious purpose. According to this, obviously, it should be for infectious control
If there
purposes.
were, for example, an asymptomatic patient on a general and acute ward, the ventilation would be doing nothing to try and help dilute the amount of viral load in that ward.
It would be, no, so the ventilation would be there. If it's 6 air changes, that would be helpful, it's good.
But it's not.
But many wards, older wards, don't even achieve that. But the point is you're not even recognising it in these are the guidelines. So these guidelines are, in my opinion, out of date.
Right. Can you help me with that? Does the guideline even talk about
It doesn't. It says there's no higher risk on normal wards, and the only purpose in a normal non-clinical spaces and general wards is about controlling odour, making the place comfortable, and you shouldn't be trying to use too much energy. And patients and healthcare workers are at no greater risk. It's written in my report. I've only quoted what they've said. And in the light of the COVID pandemic, I'm afraid I don't believe that's fit for purpose. And I've said that purposely and deliberately, saying that. And I'm saying it now, purposely and deliberately.
Just a few other matters, please, on this. I think you've mentioned already that the HTM guidance says 6 air changes an hour for a general and acute ward, but in your report, you suggest that the evidence shows that actual ward ventilation rates are lower than that.
Yes.
Can you help? Is that dealing with across the UK, or is that based on English studies? Are you able to help with that?
Yeah, I can, yeah. Right. First of all, we've got a lot of very old hospitals.
Yeah.
Right, hospitals are built at different times, and we have Victorian hospitals, Nightingale wards that are just open the windows, and they're very prone to whichever way the wind blows, basically, in those situations. Whether they achieve, you get great variation there in the amount of air changes, as I think I say in my article here. But for example, the ward that I work with closely with Adam Brooks Hospital. I'm involved in a study there. But when we measured the rates there, they were considerably lower, I think less than 1 air change, for a mechanical ventilation system. Sorry, I need to find it's in here.
You say paragraph 257, if it helps you. The evidence would suggest that actual
could you put this up? No.
Yeah, actual ward ventilation rates are often well below those specified in the HTM. For example, at Adam Brooks, as you've just been telling us, Butler found that delivered mechanical ventilation rates to be between 0.96 and 0.73 air changes on 2 medicine for the elderly wards, well below what was deemed acceptable in the 1970s and far below the 6 air changes that we've got now in the 2021 HTMs.
Right. So this encapsulates what I'm saying here, right? So now in the current HTMs, it's 6 air changes is the standard. When the building was built in the 1970s at Adam Brooks, on that one, it was 2.5. So that was the standard. It was designed to that, which is considerably lower than what we have now. Whether that's a right standard or an acceptable standard is another matter. But even then, when we actually measured the air change rates from the mechanical ventilation system, and what we do is we actually put a hood anemometer over the grills to see how much air has been brought out, we found it was less than 1 air change. So it was not performing to its standard then, and way below the other standard. The bottom one there, the Nightingale ward, basically that's a ward with cross ventilation, lots of windows and no mechanical ventilation. And there's huge variation there because of basically how the wind blows, basically, and whether the windows are open. There are some other, when I was writing this report, I didn't do any
Can I pause you there?
Yeah,
because I think we've got the point there that there is great variation depending on the age of the hospital, type of ventilation they've got, and the ability to reach now that the guideline of the 6 air changes an hour. But help me about this. What do the HTMs say, if anything, about non-clinical areas and the ventilation that's required, for example, in a staff room or where the cleaners go to get equipment?
Right.
Do they say anything about it?
No and yes, right? So largely no, right? But if I can just sum it up, right? So I've given the flavour of what it says. Basically, it's saying these are ancillary paces. They're not that important, right? In terms of the ventilation is for odour control and that. You then have a great long list. So there's very little on ward ventilation actually written in the text. What you have is a big table with various spaces listed. So in that table, which covers about 4 pages, you will have things like ancillary spaces. Some will be a sluice thing, a ward toilet. I can't remember whether there's an office building, a waiting area, how they're gradated, but they'll have usually something, an air change rate, and generally, I don't know, I wouldn't like to comment at this bit, but that's how they treat it, right? It's kind of an also-ran space.
Understood. So there is a concentration, if that be the right phrase, on the high-risk clinical areas.
No, the high risk according to the criteria of, to me, it's not concentrated on the high-risk areas from a COVID point of view.
Sorry, I didn't mean to cut across you. Do you think that the HTMs in general reflect the risks of transmission from airborne infectious viruses?
I don't think they do at all.
Right.
And from what we know and what we know about transmission of COVID, they don't adequately reflect this. They do put a kind of preamble on them saying we wrote these before the COVID.
I follow that, yeah.
Which they do stress, and yeah, that's reasonable. Yeah.
Just before we break, if I may, my lady, can I just look briefly, please, at the interventions that can be used to supplement ventilation? And, Professor, it's dealt with in your report starting on page 97. Obviously, opening a window, but that is subject to wind direction, strength of the wind, comfort of the patient. If it's winter, that's probably not going to be hugely practical.
Well, I'll just list them, but they're very useful. Obviously, you could open windows. It's a good way to boost ventilation, but there's lots of downsides. You've mentioned winter. You freeze the patients in winter. That's not a good situation, especially if these are patients who are very ill and need to be comfortable and can't maintain their body temperature. You also get pollutants in from outside. You get particulates from traffic. It's not good for respiratory health at all. Fungal particles are not helpful either. Noise, you get noise traffic. You know, there's a whole load of things. And also, once you've opened them, when you've got a deep plan space, you can't necessarily get good ventilation. You know, it's good in that area, but not further in. So there's limitations, that's what I would say.
Now, assuming that we are dealing with not a new hospital, but one of the older hospitals in the estate, clearly you can't rip down the ceiling and redo the ventilation, or not easily and certainly not cheaply and quickly in a pandemic.
It's hugely expensive to change and upgrade ventilation systems, and disruptive as well.
So the kind of portable or more easily easily built into options include portable air cleaners, is that right?
Yeah, portable, usually they're portable, but we call them supplementary air cleaners. Supplementary devices that help to remove pathogens or nullify pathogens in the air. Pathogens, by the way, can be bacteria or viruses.
Fine. And helpfully there's a figure there giving us an example of what one may look like, but it's easily to put into the ward or the room or whatever you want to.
You have one, you have several in this room, but there's one there.
Thank you very much. All right. There are what are known as upper room UV lamps. What are they, please? You can take that down, thank you.
Right. Upper room UV, it is a technology where you're using ultraviolet light. So we can use ultraviolet light at 254 nanometers. That's UVC light. That actually, when the photons of light hit the virus, they actually destroy the genetic material and prevent it from being able to replicate again and cause infection. So upper room UV, you can put UV in air cleaners like that in a box. So they're doing the same as the filter, the HEPA filter, the high efficiency filter, although the technology is different. Or you can actually put them on fittings up under the ceiling at high level above people's heads. You can't see the actual field, and create a UV field. Now, this is a very old technology that was used in the 1930s and 40s, right up to the 60s in the States, on TB wards. And what you're doing is allowing the natural air convection currents to take the pathogens, in the case of TB, through the field, and it's getting zapped. It's above the heads of people, so it's safe, but you can get a huge equivalent air change rate.
So pausing there,
So
there are a number of ways of trying to improve the ventilation in a ward, in a staff room, if we wanted to, in any number of settings. And I think you say that these portable interventions have a role to play in a pandemic, because there's a balance that needs to be struck between ventilation in non-pandemic times and the ventilation that may be required during a pandemic.
Yeah, I think this is, well, first of all, I'm not the only one saying this. Sage EMG said this as well, right? But to be honest, I actually was, throughout the pandemic, I had a central role in trying to promote this. I could see that no one was doing this, so I actually got these trials off the ground to Anne Brooks and to do that. So I was very much an instigator in trying to promote the use of this and get the trials to get the evidence. Because I could see that we hadn't got the evidence. Yeah. Going back to what you said, they've got huge potential. You've got an estate, money short. In everything, we should be looking at utility. What can we do? The biggest bang for our buck. So we've got wards that we can't necessarily upgrade the ventilation system. And actually, do we need the ventilation? You know, in a pandemic situation, if you've got a ward that's used for cohorting patients, you might need a very high ventilation rate. But when it's not being used for that, you don't need as much. You're not going to change the whole ventilation system for that. It costs a fortune. But you can bring in portable air cleaners and, in theory, achieve the same effect relatively cheaply. They're very flexible. And these are things that should be looked at, in my opinion.
All right.
That's what I'm trying to say.
I think you made reference there to SAGE, and they published a report in November 2020 where effectively they endorsed the use of portable air cleaners to provide supplementary ventilation in spaces that were poorly ventilated.
Absolutely, yes.
Now, can I just ask you...
That was a very useful document as well. There was nothing out there before that.
Yeah, because is this the position that there were no guidelines to help hospitals as to what type of portable ventilation they should or might think about installing? Yeah.
Well, I was looking at this back in 1999 when I first started looking at this. There was no guidelines. That was upper room UV. There's been no guidelines at all until the pandemic. So we knew these technologies could potentially be effective, but nobody knew how many filters should we put in a space, where we should put them to best effect. We still don't know. It's very difficult. It's a complex fluids mechanics problem.
So is there effectively a sort of ad hoc way that the hospital might decide to do it, and it might be done in one way in one hospital and another way in another?
Yeah, this is what happened. I can only speak from my experience of what I observed in various places, but people put, they were put in wards, but they were sometimes put, not by us in our trial, but sometimes put in corridors, probably having a minimal impact. If you put too small a unit in, it's not going to have the effect. So
now, pause there, because it's right to note that since the emergency stage of the pandemic finished, in May 2023, NHS England produced 2 technical bulletins which effectively provided some practical guidance regarding the use of filters and UV air cleaning devices. Is that correct?
Yes, they were built on the SAGE initial document. They were very welcome, in my opinion, because they, again, brought it to the forefront and the potential for it. But the trouble is that I'm just going to use a term here, the applied research is not there. The fundamental research is there. We know that these things kill the virus and clean the air. How to use them and where we should use them to best effect is not. And so the guidelines can only reflect the research. This research should have been done for the last 20, 30 years, you know? And because it's not there, we need to do it.
Final question for me on this topic, please. I just want to go back to UV lamps. You mentioned that they obviously may pose a degree of risk to health.
I would say that the risk of the upper room UV is 254 is fairly well known. It's fairly minimal. The biggest danger there is if someone does something stupid like climbs on a desk and looks up into the UV. They're blinded, so they've got baffles to stop people looking inside. So you're shielded. You can't see them. That's an obvious thing. Also, if there's a reflective surface that they reflect onto someone, they can irritate the eyes, basically. The other one, 222 nanometers.
Well, I don't probably need to descend to that, but given that there is a degree of risk from a UV lamp, do you think there are more advantages to HEPA filters, the portable units, than there are over the UV lamps if we are looking at proposing one type of portable ventilation over the other?
I think that the HEPA-filtered portable filter units are an existing old mature technology that's well understood and therefore is ready to go quickly, and we should see if we can get as much utilisation out of that. But I also think the potential bang for your buck of, say, upper room UV is well worth looking at. We need some trials to look at that because that might be useful as well.
I'm going to move on to a different and final topic with the Professor.
Certainly, I shall return at, well, let's say 15 minutes.
Thank you, my lady.
You can all work out what time that is.
Ms Carey.
Thank you, my lady. Professor, in your report at part 5, which starts on page 104, you set out key findings, which are effectively a summary of all of the detail that you've included in the preceding pages. But can I see if I can summarise it further, if I may? And please correct me if I'm wrong. But I think your key findings can be summarised as follows: that COVID is transmitted also via the airborne route.
Yes.
So we've got droplet and airborne, and you would say to a lesser extent contact and fomite transmission.
Yes.
And if you were to be asked whether you think there is more aerosol transmission than droplet transmission, would you be able to opine on that?
I would most definitely say that I believe that there is more aerosol transmission, airborne transmission than droplet. The precise figures I couldn't tell you at this moment.
I understand. All right. You consider that the majority of the exhaled viral load is in aerosols, either smaller particles.
Yes, I do.
And it's the aerosols that penetrate deep into the lung.
They penetrate up the nose to the receptors and the upper respiratory tract, and the smaller aerosols penetrate deep into the lung, but they penetrate into the respiratory system.
From your perspective, the 5 micron distinction that we looked at earlier does not accord with the physics.
Yes, definitely.
And the 100 micron diameter should be the dividing line between droplet and aerosols.
In my opinion, that should be the case. Obviously, it's a little bit of a movable feast depending on things, but basically that's it's the ballistic to the aerosol.
Well, that's what I was going to say, and the reason for that dividing line in your evidence is because particles less than 100 microns can travel longer distances, float in the air, whereas over 100 microns they behave ballistically.
Yeah, and to add to that, the ones that float in the air can be inhaled.
Yeah, quite.
Yeah, whereas the others, it's very difficult to be inhaled, right?
Right. You consider that to concentrate on aerosol-generating procedures is to lose sight of the fact that not only do some AGPs produce fewer aerosols than coughing, but we lose sight of the fact that breathing, talking, shouting, singing are ways of producing infectious aerosol particles.
Yes. However, I would like to just add that in saying that I believe that there's too much emphasis in those guidelines on the aerosol generating procedures as opposed to the natural aerosol generated by exhalation, I'm not saying that the aerosol generating procedures are not important.
I follow that.
Yeah.
Yeah. It wasn't to diminish them, but it's to lose sight of all the other ways in which one can become infected.
Just concentrate on their own is incorrect in my opinion.
I think you said to us earlier that good hand hygiene was important, but the evidence that it substantially mitigates transmission of respiratory viruses is relatively weak.
Yes, it is relatively weak, looking at the Cochrane reviews and other reviews. Nevertheless, good hand hygiene is good because there's other pathogens, bacterial pathogens, MRSA, things like that. So, I'm not against good hand hygiene. It's very important. And it's easy, that's the point. It's easy utility, you can do it.
Yeah, quite. In relation to asymptomatic transmission, which for these purposes include the pre-symptomatic stage, you consider that by September 2020 it was clear that there was widespread asymptomatic transmission.
Yes, I would say there was a strong body of evidence to strongly suspect that was going. Well, no, yeah, it was. And as a precautionary thing, we should have been concerned about it, yeah. From my understanding.
Yes, to final summary by me, whilst the fluid-resistant surgical masks are helpful at reducing exhalation of droplets, they offer limited protection against the inhalation of aerosols.
Yes.
Full protection is provided by FFP3 masks, but there are practical considerations such as the need to fit test, how comfortable they are, that may limit the utility of the FFP3.
Absolutely. They when fitted properly, they prevent aerosol inhalation. an infection by that route, but they're uncomfortable, they can irritate the skin. There's a whole lot of baggage that comes with them, so the utility's not so good.
And finally, as we just discussed before the break, Covid-19 highlighted the need for good ventilation in healthcare settings and indeed in other settings.
Absolutely, absolutely.
Can we turn then, please, to your recommendations? And, Professor, they are at 112 in your report. And perhaps if we put those up on screen as well, it will help those following. Now, some of these we may have touched upon already in your evidence, but your first recommendation is there needs to be a more multidisciplinary approach taken to future pandemic preparedness by the government, including but not limited to hospital IPC, include scientific advice from experts similar to the SAGE Environmental Modelling Group, but also working on pandemic preparedness as well as the emergency response. In a nutshell, why do you say that there needs to be a multidisciplinary approach, and who should be part of it?
Well, having looked at an awful lot of evidence and read an awful lot of papers and looked at an awful lot of reports, what becomes absolutely clear to me is that some of the fundamental errors, in my opinion, or assumptions, could have been maybe avoided, or things could have been flagged up if people had had the expertise from certainly from the engineering physics background and understood more about how aerosols behaved. Often people are coming from reading what other epidemiological studies have done. Their training is in medicine or in microbiology or nursing, and they maybe miss things that I would spot. So I'm not saying it's me but we need someone. There's very few people with. I straddle both biology and that. That's not a common environment. But we need to have people, and there's a whole raft of people coming through from the pandemic who've learned from the engineering who've gone into this area to look at because of the pandemic. So they're out there who have that kind of physical, biological science side that could give extra expertise, and I think that would be very useful. I've also added it should be in preparedness rather than in response. So one of the good things that's come out of the pandemic is a whole lot of engineering schools have suddenly woken up to the fact that there is all the stuff I've talked about is actually engineering, and there's a whole lot of PhD students and other people looking at this area. So the expertise in this area has grown.
So you're drawing a distinction between preparedness and response, because Catherine Noakes was part of SAGE, wasn't she? She chaired the. She was the modelling subgroup.
Right. This is where I'm at a slight disadvantage, not being an insider in that. I know Kath very well, but she was. I understood that the environmental modelling group was something set up for the pandemic. Wasn't standing. Is it now standing? No,
it was set up. Well, I think it was set up for the pandemic. Certainly, it was SAGE's for emergencies.
Yes, but the EMG was a subgroup of SAGE.
Yeah.
It was, I think it was. Yes. Well, SAGE goes on, doesn't it, in various ways? It's not just for the emergencies, or have I got that wrong? No.
Well, we're going down a.
Sorry, I'm showing my lack of. This is.
Sorry, it's just that you're saying make sure that the likes of you or Catherine Noakes or people with similar expertise are involved in planning, not just response.
Yeah, make sure. Yes, when you're preparing for the next pandemic, get people from all disciplines to get a good idea what's going on. So Catherine Noakes joined SAGE, but not at the beginning, I think later on, actually, as well.
Right, we can check her evidence. I've already heard from her, so we can check.
Okay.
Yeah.
Right, Ms. Carey.
Can I ask you, please, you've always alluded to the fact that at present it's not able to say the amount of transmission is airborne, the amount of transmission is droplets. I don't want to go over that again, but recommendation 3. Much confusion currently exists in the terminology used in the healthcare system guidance from the UK. And that's before you even add the WHO guidance into that. What do you say, and how do you say we can resolve differences in terminology?
Right, well, first of all, to say the WHO is actually looking into this whole area and is making slow progress from what I can understand. On this whole issue. And I think one of the things that we could do is actually some education so that people who are from a clinical background would actually have explaining what an aerosol is and how things work. Then they would have a better understanding, and then that would start to bring people together. The problem is that people are often talking about the same thing, but using totally different terminology and being totally confused. And with a bit of education, the problem is that some people are well, a little reluctant to change their opinions. I think that's fair to say. You know, but,
how do you think the UK should go about changing the terminology?
well, I think they've got to do it in step with the rest of the world. I don't think you can do that, but I think this education thing, you know, once people start to understand how these things behave, then they realise the need to change that terminology, and that would help people to come to agreement, I would have thought. It's when people just looking at their guidelines from their discipline and don't understand maybe the fundamental physics going on underneath.
You have referred in your evidence already to the fact that you consider there is a need to revise and upgrade the HTM guidelines on hospital ventilation. So I don't need to ask you about that.
Yeah, I do believe
that's a firm recommendation you make. And in relation to portable ventilation, as we were just discussing in the break, do you consider there is need for more evidence and indeed guidelines on the deployment of portable supplementary air devices?
These are, you know, certainly portable air filters, HEPA filters, are low-hanging fruit. They're cheap, easy. We know they clean the air. We know they do a similar job to ventilation. If ventilation's good, then portable air cleaners are good. What we don't know is how many do we put in, where should we put them to best effect? So it's applied research, which in the big picture of things is fairly cheap and in it, you know, is quick to do. But we need to know where we should be putting them to get best effect. You know, and that should be reflected in the HTM guidelines as well, because they should be just as a standard procedure, I would say.
You consider there needs to be, at your recommendation 6, a need for further multidisciplinary research to better understand how air and indeed infectious aerosols move around hospital wards.
That goes back to the slide that you showed, which showed the aerosols, the particles all on one side of the ward. In other words, we assume when we talk about air changes, and we specify air changes, we assume that it's all completely mixed and it does the job. But when we do CFD, we suddenly realise, oh, there's pressure gradients, things are, that diffuser is actually putting the risk up for these people in this side of the room. The aerosols are going out into the corridor. We need to understand how to do that better. Again, it's applied research.
Right. Now, that recommendation there, you concentrate on hospital wards, but just thinking about all those non-clinical areas.
Oh, non-clinical as well.
Would you include those in there? That generally, we need to understand how the air moves around the hospital.
Yes.
Yeah.
Yeah. In fact, non-clinical hospital waiting rooms are really important. Waiting areas are really important areas.
The final one I would like to concentrate on before I conclude is masks. All right. Now we have, through you, examined the efficacy and otherwise of FRSM versus FFP3, and you've mentioned a number of times that there are potential practical problems with widespread use of FFP3. It needs to be fit checked. It's uncomfortable. It leaves, does it not, staff, patients, whoever wants to wear them with a slightly binary choice.
You're absolutely right. This was the one thing that, my brief was to look at the science of these things, and as I looked at it, obviously I knew about the science of both masks, but when I looked into how they were being used under the guidelines, I realised that all we had was essentially, in the NHS, a binary choice. You go down one route, that's respirators, if that's kind of specified, in which case then it falls under the cost regulations and HSE. Otherwise, it's surgical masks. And from a point of view of preventing airborne infection, from the science point of view, one is it's all or nothing. These, if they're fitted properly, the FFP3 masks prevent airborne transmission. The surgical masks, there may be a little bit of inhibition, but they're not that effective. So they allow the aerosols to get through. And as a scientist, that made me think, well, there's an awful lot in between there. Surely we can improve and get something with, I want to say utility, if you don't mind. These have got the surgical masks, good utility, but not effective against airborne. FFP3, very effective, but not good utility. They're difficult. They come with baggage, if they're right.
Now,
in the ground, there must be maybe an optimum solution that we could achieve.
Let's look then, please, at what you say on your page 113 at recommendation 5, which is a good introduction to this recommendation. There you've made the point already, FFP3 provides better protection for healthcare workers caring for patients with COVID than surgical masks. It raises the questions as to whether the FRSMs provide adequate protection to healthcare workers when caring for COVID patients, or indeed for those who are asymptomatic.
Yeah.
Therefore, barriers in the way of wider respirator use, whether due to guidance, regulation, fit testing, supply or comfort, should be addressed urgently by the UK government to ensure that more effective respiratory PPE is widely available before and during the next pandemic. That healthcare workers are better protected. In particular, consideration should be given to alternative face mask solutions, such as FFP2 masks with ear loops, which offer superior protection against the inhalation of infectious aerosols compared with surgical masks, while being more comfortable than FFP3 with the head straps. And of course, you don't need a fit test.
Shall I?
Now, let's break that down. I have an FFP2 to show an example of a type of FFP2, which is potentially a middle ground between the FRSM and the respirator. Why do you think there should be more consideration given to that middle ground?
Right, so this really comes from public health and also from the point of view of reducing nosocomial infections. First of all, I don't want to be prescriptive. It's just that when I looked into this, there was the FFP2 mask with ear loops, which was already there. So it was a kind of low-hanging fruit that might be applicable if used in the right way. So what we have at the moment is we have a binary situation. And when you go to the FFP respirators with behind-the-head straps, they're uncomfortable, they need fit tests, you get hot. There's a whole load of baggage that comes with it, which makes them difficult when you're in a working environment. And they fall under the COSH regulations, so they need to be fit tested, and there's a whole load of stuff there. These don't stop the aerosols, but in the ground in between, from the point of view, I'm interested in the greatest benefit for the greatest number. Right, so the greatest benefit for the greatest, that's very much like a public health point of view. You're trying to use interventions that mitigate the transmission. They don't do it perfectly, but they reduce it. And when I was looking into this, I was finding studies where people had looked at FFP2 masks with ear loops, especially in Germany, and they were finding that there was a performance that was 50% better than the surgical masks. They were performing much better than the surgical. And these were straight out of the box without adjustment of the nose loop. And when you adjusted the nose loop, you got much better performance. They're not fit tested. No. So these would fail as respirators, and we're not trying to pretend that they're behaving as respirators. They're behaving as masks. But potentially, that might be a middle ground that's got better utility, causes less discomfort to healthcare workers, provides better protection against aerosols, and is reasonably cheap and is easier to use. And I'm not wanting to be prescriptive, but what I'm saying is this is an area which we should be investigating, or the health service should be investigating.
So is your recommendation, in short, that the government needs to investigate that middle ground and whether there is a form of protection, whether it's FFP2 or not, that can provide that balance between the higher levels of protection with the added uncomfort and all of the baggage, as you say, that goes with FFP3 and the lower levels of protection.
Absolutely. I'm looking, there will be an optimum sweet spot, and that might not be the same for every environment. And remember, it's got to be taken into account with the viral load in the air. By no
point, Scary, thank you.
Thank you. All right. It's finally this, because there are some questions from the core participants.
Right, sorry.
Would you support a recommendation that there needs to be better education about airborne transmission for healthcare workers and those completing risk assessments?
Definitely.
My lady, that does conclude my
Just before
questions.
I turn to questions from the core participants, clinically vulnerable families wanted to ask you questions. I'll tell them down, but I'll ask in summary because I think they probably go without saying. If you improve ventilation in hospitals and obviously protect in so doing clinical and non-clinical staff, it goes without saying, does it not, that it would also help protect patients?
It does, yes.
It also goes without saying that the most vulnerable patients will be the better protected.
Yes.
Thank you. And this is a question that I was concerned, thinking about too. In relation to portable air cleaners, in normal times, i.e. non-pandemic, do hospitals have these portable air, or are they only brought out in emergency?
As far as I know, they weren't being used, but they appeared during the pandemic. They've been known about for years.
But the question is, I mean, do all hospitals have a supply of them? Should we be using them all the time?
I take that back. I used to be Professor of Medical Engineering at Bradford University, and I certainly was aware that there were units being sold. They were probably being used in operating theatres to provide extra ventilation. So they were being used in certain specialist places. It's an old and well-known technology, and they're easily obtainable, you know. Has that answered the question? Sorry.
Well, I think the answer is that the more of them about, even in normal times, the better ventilation you have, the better the chances of patient and healthcare worker safety.
Yes.
Thank you. Right, now...
My lady, can I just correct one thing? Professor Beggs was kind enough to indicate that there are some revisions to paragraph 18.
I've got them.
Your ladyship will have them, but they've not been read into the record, and I'm asked to do so. It's two minor revisions, but essentially the sentence should read, but now in August 2024, it acknowledges that the inhalation of infectious airborne particles, i.e. aerosols, is likely an important route by which SARS-CoV-2 and other respiratory virus infections can be transmitted. And in the final sentence, where it currently reads droplet/aerosol, it should read droplet/airborne.
Thank you.
Thank you, my lady.
Excuse me, there's one thing you missed there. Sorry, I'm looking at it. It should be Appendix 11A, which I think it says.
That's fine. We'll deal with that. Thank you very much, my lady.
Thank you. I'm now going to allow some of the core participants to ask you some questions. Professor, they have limited time, so I often have to say this to witnesses. Please remember when giving your answers that the longer your answers, the more you eat into the time that I've not so generously allowed them. Right, Miss Fubister, where are you? There you are.
Thank you, my lady. Professor Beggs, good afternoon. I represent John's campaign, Care Rights UK and Patients Association. A lot of our questions have actually already been covered, so I anticipate we'll be a little bit shorter, you'll be pleased to know. So starting with this one, you explain in your report, and you've mentioned today, certain differences in opinions among scientists, whether between clinicians and physicists or otherwise. When scientists are offering information to government or advising government, do you think that those making decisions should be given an overview of differing opinions?
Yes. I think the one thing it's not cut and dry. You know, there are quite a few clinicians who also share my viewpoints. They're not from an engineering or physics background. I think that people need to be aware of the physics underneath it. So you use the word opinion. They need to be, a lot of this is known, it's fact, it's well understood about behaviour. They need to be aware of these things, underlying things, then that will influence their opinion on the epidemiological evidence. Does that make sense?
Yes, it does, thank you.
Yeah, so I think they definitely need to be aware of the science. So if, for example, I'm not trying to give any real situation, but if you have someone who's from a public health background and they're talking about airborne transmission, they will talk about what they've learnt and what they know from the textbooks and the epidemiological trials, but they won't necessarily talk about thermal plumes or any of the stuff that I've been talking about here. And so it's very helpful to have that knowledge as well so that you can interpret the epidemiological data.
And that feeds into your recommendation about having a multidisciplinary approach.
Yes, that's why, hence why I've said it.
Thank you. On to another question. If I could ask you to look at page 65 of your report, at paragraph 165. It's right at the bottom of the page. If you can pull that up, if you just have it in front of you. Ah, yes.
Where is it? 65?
It's now on the screen, I think.
Yeah, and what is it? 165?
Paragraph 165. So the paragraph starts and here you say that there were studies that showed that most of the virus was in smaller respiratory particles. And the second sentence from the bottom, so you did touch on this briefly already, but this is just to pick out a particular point. You say that the authors of the PIP report were aware of Lindsley et al.'s findings and commented on them in their report. However, their conclusions downplayed those findings in favour of the assumption that most of the viral load is in the larger droplets. And so I have two questions.
Yep.
The first is that based on the knowledge available at the time, should the authors of the PIP report have given more credit to the Lindsley report? Or taken it on board more rather than downplayed it?
They looked at... They were reporting the consensus at the time was that the virus was in the larger droplets rather than the small aerosols. Lindsley had just come out, and I think they should have taken more notice of that because this was actually hard evidence. This was actually experimental evidence which undermined an assumption. The assumption, I don't think there's any evidence out there for the virus being evenly distributed throughout all the respiratory particles in the large droplets. I'm not aware of it. It's always been an assumption that's been repeated from way back. And here was some hard evidence coming out saying, no, it's in the small aerosols. Well, you've got an experimental evidence against an assumption. Therefore, in my opinion, I probably should have given more weight to that. But I'm not going to be too harsh on that. It just come out. There's, there was a lot of other evidence and that they were
Understood.
going with, and
And if
perhaps they were being cautious. That's what I would say.
If that report hadn't been downplayed so much, do you think that might have made a difference to the thinking about the transmission of COVID-19? Undoubtedly, because that would have immediately undermined the assumption of the droplets, as far as I'm concerned. And there's numerous studies now. They're on the public domain, and you can see that the viral material, the RNA, and live viruses. The bulk of it, over 80%, is in the small aerosols in some of these studies, implying that they're coming from different places in the lungs. That would have had a profound difference to that preparedness. Thank you. Those are all my questions. Thank you, Madam.
Thank you very much, Ms. Hubert. I'm very grateful. Mr. Thomas.
Thank you, Lady. Professor Beggs, you'll be pleased.
Are you switched on, Mr. Thomas?
Sorry. Different position. Professor Beggs, you'll be pleased to know that one of the questions I had has been you've already answered, and forgive me for the positioning. I'm representing and asking questions on behalf of FEMHO, the Federation of Ethnic Minority Healthcare Organisations. And just to give you a little bit of context, FEMPO is deeply concerned about the challenges surrounding infection prevention and control, particularly the disproportionate impact it had on Black, Asian and minority ethnic healthcare workers and patients. So with that context in mind, let me ask you the one and only question that remains, and it's this. In your report at paragraph 229, you reference the SAGE report, Masks for Healthcare Workers to Mitigate Airborne Transmissions of the SARS-CoV-2 virus, published in April 2021, which places good ventilation above the use of surgical masks in the hierarchy of controls. Question, considering this, do you believe that reducing viral load in the room air in healthcare settings should have been prioritised above the use of surgical masks?
Yes. And that's what they are implying there. But as you saw from the guidelines, which were written before the pandemic, it wasn't on the radar in other than a few places. So from the point of people that you're representing, this is hugely important because wherever they're working in the hospital, whether in a clinical capacity, frontline facing patients, or in a more ancillary capacity, they are exposed to potentially aerosols that are produced. And therefore, at least, I'm not saying that the guidelines were wrong in terms of the ventilation rates, if they've been applied or applied. What I'm saying is that it should be recognised in the guidelines. However, they were written before the pandemic, and that's why they need to be updated completely. But it's very important that it's not just the clinical spaces, it's the whole of the hospital, if that makes sense.
It does, thank you. Milady, counsel for the inquiry has already answered the second question, so I don't need to ask that one.
Thank you very much, Mr. Thomas. Very grateful. Mr. Markry. Are you switched on?
I hope it works.
Sorry, it's my mantra.
It is, again. Professor, I ask very few questions on one specific topic. I ask them on behalf of the Frontline Migrant Health Workers Group. To help orientate you, it's page 32 of your report, paragraph 78. And it's the section of your report that deals with the risk of inhaling an infectious dose.
Yep.
So if I can just recap the evidence you gave this morning, really to contextualise my question, but also to save some time, because I have limited time. The risk of becoming infected increases with the amount of particles in the air, i.e. the concentration.
The risk of becoming infected increases with the increased number of particles that you inhale. So if you're in somewhere with a high concentration in the air, so the risk goes up with this more in the air, yes.
Exactly.
Yep.
And the second risk is it goes up also with the volume of air that one inhales.
Yeah, so if you're in a gym and you're working out on a treadmill, you're going to, a huge amount more air is being inhaled. And so therefore, if there's a high concentration, you're going to be taking a load more viruses in. But this does apply in a healthcare setting to people who are actually doing more manual work, pushing loads. I assume someone like a porter would be affected by this. They would be working harder in that situation, so their lung capacity would go up in that, yeah.
Exactly the point. It's on the physical exertion point that you make reference to in that paragraph. When you exert yourself physically, it has a significant difference in respect to the volume.
Yeah.
Can I give you the example that you use in your report, perhaps to save a little time?
Yeah.
A resting healthy adult inhales 6 to 9 litres of air a minute.
Yeah.
The same adult walking at a moderate pace inhales between 20 and 40 litres
Yeah, well, I'm someone doing hard exercise, I think it goes up tenfold. Yeah, it greatly increases. So therefore, if you've got particles in the air, you're sampling them at a faster rate.
3 minutes to go, Professor. You say that physical exertion is an infection risk that is often overlooked. Now, do you mean overlooked from an IPC perspective or just generally?
I think both, actually.
Okay, thank you. I'll park that there if I can. So as a risk factor, exertion, you've mentioned porters, porters who are lifting and moving patients, and cleaners who are doing the physical labour of cleaning. That would have an implication in terms of infection, both near field and far field.
Both near field and far field, the only mitigating thing against that is they may not be in that place for that long, especially porters. They may be in to collect the patient and then out, so their duration would be less. However, it may also be for cleaners, but then some people may be in the space for longer. Yeah.
Well, quite. If we take as an example a cleaner, would you agree that a cleaner who's working longer hours, moving between wards, COVID and non-COVID, and the non-clinical spaces that we've referred to in your evidence today, would be at a high risk precisely because their duration is increased and their exertion is increased?
You'd have to do the calculations, but in theory, that could happen, yes. What I do is I do calculations and I do the sums and then see how that works out, how many likely viral particles are going to inhale. But those are all factors. In simple terms, the more you inhale, the higher the concentration, the longer you spend in there, the greater the risk. That's
all things being equal, the longer the shift and the harder the work.
Absolutely,
the
if you're
the
in
risk.
there. Yeah.
Thank you very much, Professor.
Thank you very much, Mr. Murphy. Very grateful. Right, I think that completes your evidence, Professor Beggs. It's been a long day for you. I hope it's not been too tiring. It's been extremely helpful.
Thank you.
And some very interesting points that you've made. And I'm very grateful for all your care in preparing the report and, of course, in giving your evidence today.
Thank you.
Thank you for your help. Right, 10 o'clock tomorrow.
Yes, thank you, my lady.